Dear all, I welcome you all to this 8th annual conference of SHAKE on the theme of saving deaths and damages from heart attacks. Let me express my sincere congratulations to Dr. Brajesh Mittal and the other colleagues for organizing SHAKEHEART 2024 and for their tireless efforts in creating awareness to prevent heart attacks. I am hopeful that this conference will provide more insights in educating about acute heart attacks and narrowing the significant gap by creating awareness of the importance of early recognition and early treatment of this major killer. Medical and paramedical personnel require a solid understanding of new techniques and technologies to provide high-quality care, and I am confident that these sessions will equip them with this knowledge. In addition to imparting more skills to the medical fraternity, such conferences and workshops will greatly improve the delivery of cardiology care. The conference will be a great success, and I wish you all the best.
So, our next session is a keynote session. I invite Dr. Fakhri Aldeeb to please join as a session chair, and with co-chairs Dr. Rajesh Rai Pancholia and Dr. Georgie Thomas. Friends and colleagues, is Dr. Peter Kala online? Not yet? So, the lecture is already recorded. Please be seated. I just want to give a very brief intro for Dr. Peter Kala. This session and this title you can see is Saving Deaths and Damages from Heart Attack. It is the theme of our very movement. Dr. Peter Kala is also very, very consistent, and it is the consecutive 8th time that he is delivering his talk. First time in November 2015 in our first meeting, and in our second meeting, and our third meeting. Consecutive 3 years he attended in person. He flew all the way from Czech Republic. His main theme and background of his life story is he was clearly associated, and he was the chair of the Stand for Life program, which was the initiating movement from where the deal was sealed in favor of primary PCI. So he was the chair of this for so many years. So there can be no other person better than him to speak on saving deaths and damages of heart attacks and 4 decades of experiences. So with this, I leave the dais with the chair and co-chair, and the lecture is pre-recorded. We'll have 20 minutes lecture, 5 to 10 minutes discussion before breaking for the lunch. And you can also discuss among yourselves. Thank you.
Thank you so much, Dr. Mittal, for your introduction. It's my pleasure to be the chairman for the first keynote in this conference. First of all, I would like to thank Dr. Mittal for his kind invitation. We have been working together for 2 decades now. It is a pleasure. It was a nice journey. We had it together. We worked initially when we came first to Dubai in the same hospital, and then pathway took us to different areas. And I have been an integral part of this ShakeWave conference from the beginning. I'm very honored to be part of it. It's very successful, very inspiring, experience. It's my pleasure to have my co-chairman, Dr. Rajesh Rai and Dr. George Thomas. Thank you so much for joining us here. The motto of this meeting is to save hearts. We know that heart attack is the first cause of mortality worldwide. We're still having this problem for many decades. As cardiologists, we have been doing our best to overcome this. We achieved a lot of success in the last 4 decades, and we have expert in the field, Dr. Peter Kala. He's the head of Department of Internal Medicine and Cardiology in the University Hospital Brno in Czech Republic. And he is going to talk about what we have achieved over the last 4 decades to reduce cardiovascular mortality. So I would like to welcome Dr. Kala for giving his presentation. It will be online, right?
Hello, dear ladies and gentlemen. It's my great pleasure to be with you, and I would like to thank Dr. Rajesh Mittal for his kind invitation to your excellent meeting, SHAKEHEART 2024. I'm Peter Kala. I am from Brno, Czech Republic, and I would like to share with you some thoughts about saving deaths and damages from heart attacks, about 4 decades of insights. So this is a really long and rather successful story. And I will touch primary PCI versus thrombolysis. I will touch POBA versus stenting, stent versus DES, deferred stenting, arterial approach, multivessel disease, cardiogenic shock, gender disparities, guidelines, and some cases as well. So we very well know that primary PCI is the best reperfusion strategy, and it's safer, it's faster, and more effective than fibrinolysis. And we have really good randomized data and meta-analysis. Besides that, it makes really better outcome of the patient regarding death, regarding myocardial infarction, stroke, including intracranial hemorrhage, and also, of course, the need for urgent revascularization. We also know that if the primary PCI is done timely, within 2 hours, that means 120 minutes, so it's really the best possible possibility. And we can transport the patients from community hospitals or from the by the emergency medical service directly to the cath lab, passing the community hospital. What we also know that the stenting is better than balloon angioplasty only, and we also know that drug coating stenting is better than bare metal stenting. What about deferred stenting? Because one time, once it seemed to be relatively interesting, but there was some meta-analysis of trials with deferred stenting versus stenting, and there was no benefit. On the contrary, if we don't stent, the patient should have a little bit higher risk for second procedure and maybe also some higher risk. About the radial approach. Of course, we started with femoral. After that, we switched to radial, but based on data. And we have very good randomized data. And there is meta-analysis of more than 20,000 patients. And if we are talking about the randomized data, so you can see that all-cause mortality is significantly lower if you use radial approach than the femoral one in patients with ST elevation myocardial infarction, in patients with STEMI. And the difference is 23% in favor of radial approach. And it corresponds with the class 1A recommendation based on European and US guidelines as well. What about the multivessel disease? Multivessel disease, if we are talking about STEMI population, so we face these patients in at least half of them. If you are talking about NSTEMI population, it's even higher percentage. And we have many randomized trials. And I would like to share with you some the largest one. That means the complete trial. And these are the primary outcomes. You can see the culprit only in red and complete revascularization in blue. And in terms of cardiovascular death or new myocardial infarction, it's everything is in favor of complete revascularization. If it is combination with revascularization, so the difference is even higher. So it seems to be quite clear that we should achieve complete revascularization, either by anatomy or functional significance of the lesion. And you can see again, this is meta-analysis and cardiovascular death just from complete trial. And so even the cardiovascular death is in favor of complete revascularization. Another really important topic is cardiogenic shock. And if you are talking about the cardiogenic shock, the prognosis of these patients is really still quite bad, because we have to count up to 45, maybe up to even 50% mortality at 30 days. And this is classification, probably you know, done by Society of Cardiovascular Angiography and Interventions and prognosis. So it's different. If we have patients at risk, at beginning of shock, classic shock, deteriorating shock, or extreme shock, and you can see the on-hospital mortality, the percentage is listed here, and the long-term mortality. And of course, the time, again, is the highest important, because time means muscle, but it also, especially in patients with cardiogenic shock, it means the possibility or the chance for living, not only quality of life, but survival. There is one exception. If we are talking about the complete revascularization, and these are exactly patients with cardiogenic shock, you can see the culprit lesion only PCI, all-cause mortality, and immediate multi-vessel PCI. And there is significant difference in favor of culprit lesion only PCI. So this is the only exception if you are talking about complete revascularization in STEMI. In cardiogenic shock, we should not treat all lesions immediately during the index procedure. This may be quite interesting for you, because these are data from the Czech Republic, from the whole country. And this data is about the impact of cardiogenic shock and out-of-hospital cardiac arrest on the outcome of acute myocardial infarction. This is 30 days outcome, this is 1 year outcome. And you can see 4 curves. So this one, the reference, is just acute myocardial infarction. The blue one, acute myocardial infarction with out-of-hospital cardiac arrest. But here, the yellow and the red mean patients with cardiogenic shock. In yellow, without out-of-hospital cardiac arrest, in red, with cardiac arrest. And what does it mean? How can we interpret this data? And it's quite clear that cardiogenic shock itself has the highest impact on mortality and survival of the patients. It's not about OHCA, out-of-hospital cardiac arrest alone, but especially in combination with cardiogenic shock. But we have probably some possibility to improve our quality of care. And this is data that I would like to share with you from the last week, from ACC Congress. Danger shock randomized control trial, more than 300 patients in STEMI with cardiogenic shock. And in the arm with mechanical support was the Impella. Routine use of Impella that reduced all-cause mortality at 6 months. And you can see the standard care alone, and you can see the microaxial support. That means the Impella plus, of course, standard care. And these data are really promising, and were published in New England Journal of Medicine last week. What about the antithrombotic regime, especially in cardiogenic shock? It's really extremely important to achieve some level of antiplatelet blockade. And we will have this data for patients in cardiogenic shock, DAPT shock AMI from the Czech Republic, more than 600 randomized patients from 5 countries, and we are waiting for the data because the enrollment has been achieved. So we hope that we will get the data very soon. What about the gender issue? And as you can see, this analysis was from randomized trials, Prague 1-2, Prague 18. And what is quite important is this fact, is the time interval. That means the proportion of women with time into reperfusion more than 6 hours after the onset of symptoms remain unacceptably high, because you can see that it's more than 20%, even more than 25%. What about intracoronary imaging? How to improve the quality of primary PCI? And I would like to share with you the meta-analysis of 20 randomized trials that were presented by Greg Stone at TSE last year about IVUS OCT guided PCI versus angio guided PCI. The list of the trials is here. And this was the conclusion. And probably the most important was reducing stent thrombosis by more than 52%, all MIs by nearly 20%, and all-cause death by 25%. Of course, target lesion failure was lower. So extremely important and very strong data we have. What about the guidelines? We have the new guidelines from ESC about acute coronary syndrome, for the first time, combining ST elevation myocardial infarction together with non-ST elevation myocardial infarction or non-ST acute coronary syndrome. And what is new here is ACS dividing in A, that means abnormal ECG, of course, C, clinical context, so some more holistic approach, and S, how stable is the patient. If the patient is with ST elevation myocardial infarction or very high risk non-ST acute coronary syndrome, the pathway is the same. So the patient should be revascularized within 2 hours. And that's quite important, of course, to select the highest risk population. And we have to think about secondary prevention. That is really extremely important now. Of course, we should follow the total ischemic time, patient delay, and systemic delay. And I would like to share with you some cases. So this was male 75-year-old with NSTEMI, with hypertension and hyperlipidemia, with distal left main disease. You can see it on the right, you can see it on the video. So this patient was indicated for primary PCI. And before that, we did the IVUS investigation together with spectroscopy. And surprisingly, this was mainly fibrotic lesion in the left vein. But in the proximal LAD, there was a lot of lipids. That means the yellow color. Of course, we have some parameters that measure the amount of lipid pool, but I can assure you that this was really important for the patient. So on the right side, you can see the video again. So we did the PCI with kissing balloon stenting. It was provisional stenting from left main to LAD with such result, and very good result, I would say, or at least acceptable result in the left main bifurcation. But of course, what is remaining is the proximal LAD, and as you can see here, the proximal LAD is the final result after primary PCI plus drug-coating stent. So this is non-obstructive coronary disease, and this is definitely important for very proper secondary prevention and even better management of lipids. Another case, male, 84-year-old with ischemic cardiomyopathy and STEMI with many comorbidities. So you can see that the left ventricle was really severely dysfunction, and there was mitral regurgitation class 3. After the discussion with heart team, because we had the discussion, it was possible to discuss the patient. So we indicated complex PCI, and with the support of Impella, that means microaxial pump. And on the right side, you can see the final result. Of course, it's important to mention that there was tight stenosis into this left main, occlusion of the circ, occlusion of LAD, and the right was non-dominant. So on the right side, you can see the final result. And what was very nice, because after the revascularization, the left ventricle improved, and just 2 days after the procedure, and the mitral regurg was lower. And this will be the last case, a young male with anterior wall myocardial infarction with some risk factors, typical risk factors for a young population. And this was acute coronary angio with thrombus formation or some lesion in the distal left main with trifurcation. And at that time, I decided not to continue with complex revascularization procedure, but instead of that, I gave the patient combined antithrombotic therapy, aspirin, ticagrelor, GPI, also some small dosages of TPA, and indicated VCAT plus OCT 4 days later. And the 4 days later, the pictures you can see here. So the angio was really quite good. And on the right side, you can see the cross-sectional pictures from the OCT, and below you can see the longitudinal view. And probably this is better to see because there was a fissure and some thrombus formation in the distal left main, but as you can see, a very large lumen and very small coronary artery disease. So the patient was indicated for secondary prevention and control of the risk factors. So how I see the role of primary PCI, and we have also, of course, the cabbage, but only as backup. So it has to be timely, primary PCI, within 2 hours. That is the best reperfusion strategy in STEMI. And if the transportation time would be longer, so we should go with thrombolysis and after that emergency transportation. So direct transport to 24/7 cath lab saves time and saves myocardial muscle. But primary PCI is also indicated for very high risk end-STEMI population. We should use irradial access, we should use drug-coating stents, and we should at least think about intracoronary imaging. In fact, if you are talking about the complex lesions, distal left main, bifurcation, long lesions, etc., so intracoronary imaging should be in place. Complete revascularization could be done within the index hospitalization, but with similar results within 45 days, except cardiogenic shock, where the culprit artery only should be revascularized. Cardiogenic shock with potential role of mechanical support. We have the data for Impella now. We have to think about gender disparities. And there is a role of coronary physiology that has to be better established. And of course, we have to continue in individualized antithrombotic regimes to find the optimal for any person, and including research, as I mentioned before. So thank you very much for your attention and for the kind invitation.
Thank you so much, Professor Kala, for this very insightful presentation about the treatment of heart attack over the last 4 decades. Very provocative presentation, I would say. You know, we went a long way from. I had the privilege to experience all these decades from giving intracoronary thrombolysis as a treatment of MI in the beginning, to intravenous thrombolysis, then to rescue angioplasty, and now primary PTCA. The issue of complete revascularization remains, disputable. Some studies, like the complete study, showed that it is better to do complete revascularization when it is convenient, at the same time of doing the culprit artery. In your conclusion, you mentioned that this should be done within 45 days unless the patient has a cardiac shock. Can you give us some more clear guidelines? What should we do when we have a patient with a STEMI or non-STEMI or with multiple vessel disease? Oh, okay. So maybe we can entertain this with our panel here. Okay.
Most of the guidelines say that open up the culprit artery and don't play around with the other vessels unless it's absolutely indicated. In my practice, I would tackle an extra vessel if it is 99% stenosis and there is slow flow. But anything lesser than that, with decent flows in the other vessels, leave it alone. Patient can come back another day when it's much more peaceful, when you know the hemodynamics.
But you know that sometimes we have problem with the insurance, so because they tell you why you admit the patient again. So would you consider doing this at another session before discharge, or you really favor discharging
again,
the patient, bring him another session?
I have seen both things happening. There are some of our colleagues who do it after 3 days during the same admission. There are some people who would do a treadmill after 3 weeks, 6 weeks, say it's positive, and then send the insurance and get it done. But I think we do not have a clear guideline on how much time can be taken, interval between the acute event and the second time that we go in for an intervention. So I think you would go about on a case-based, scenario where the insurance is going to trouble you. The troublesome insurances. But then again, on a clinical basis, I think we can give the myocardium some time to recover before we go in and do it a second time. Insurance is a second thing. I mean, it's not the clinical discussion.
Would you apply this same for patients who are presenting with anterior MI or inferior MI? Suppose somebody has inferior MI, but he has critical lesion in the LAD. Would you discharge this patient, bring him back later, or would do him before discharge?
I would do it, say, after 48 hours. I've done that in my practice. Means if it's an inferior MI and if the LAD has, say, 80 or 90% stenosis, and if I've achieved a good result in the right, shift the patient back, and within 48 hours before his discharge, I would do the other artery. If it's significant. If it's a moderate stenosis, like for 50%, I would not do anything. Then assess them non-invasively later and address it at a later date. But if it's like 80-90% stenosed LAD with a RCA, then I would do before they are discharged. Definitely.
Thank you so much. All right.
Yeah.
Any questions from the audience here? Or any comments from?
Again, on that aspect, if it's a 90 plus with to meet 2 flows, I would be more inclined. But if you have T3 flows, even with a 90% stenosis, remember this patient came in without medication, without anything going on the coronary arteries. So he has lived through all the previous years with the 90%. So we going and fixing it immediately within 48 hours may or may not really help, because if he survived all this while with the 90 and the other one becoming 100, you're already starting him on the anti-lipids, you're already starting him on the antiplatelets. So the risk of him coming back with an acute MI on the LAD is far, far lesser compared to a plaque rupture or something that happened. So, you can debate both ways.
Excellent. So you believe in the power of medicine, that if you put the patient on the right medication, you are giving the patient already some protection, so you can, reschedule the other procedure when the patient is in a better, stable condition. Thank you so much.
Both ways.
Initially, the data says with the culprit vessel, do the complete revascularization if feasible in the index admission. ACC 24, they presented again and they found there was no difference with complete and the index, culprit artery only in the index event. So it is swinging it still, it's not settled.
I think, in my experience, when you have no agreement, then it has to be individualized. So for every case, one has to look at the patient and see, how stable the patient is, how symptomatic the patient is, what is the left ventricular function, and then decide what to do in this condition. There is one question here.
5,500 patients, in which the patient with have a significant lesion been randomized to the medical treatment versus invasive treatment, and there was no difference in the two arms. And the trial is still going on as a ischemia extended trial. Now almost 7 years, there is no difference.
No.
CCS.
You are mixing now. We are talking about
same
patient
time,
with
Again,
acute,
a 90 on the LAD we don't classify as chronic or acute, so it depends.
See,
it's a
Dr.
different population.
Dr. Mishra is saying that other lesion is not the culprit lesion, it's a stable lesion. So it is not to be treated as a culprit lesion, number one. Number two, but the 2023 guidelines of acute coronary syndrome of European Society has given a very clear pathway. See, the trials will keep on coming every year, but we cannot change opinion by the trial. One trial has come this way, we shift the petrol with direction. Another year, another trial comes that way. We forget what has gone to the previous trial and talk about the new trial. We have to go by the guidelines. Guidelines look at all the evidence and come with the conclusions. They say that if with the index hospitalization, if the other artery is feasible without imaging, the criteria is imaging. If you need imaging, OCT, FFR, don't do it. If you can do it without imaging, then you can do it.
That's the whole issue. As Dr. Kala showed us, the more information you have through doing, pressure physiology, study or IVUS or OCT, that will help, to make decisions. But we always have a dispute, about the timing for the complete revascularization, and I think this is going to stay an unanswered question, and it has to be taken individually.
I think it's been a wonderful post-break session, and now we are having another break, which will be for until 2:30, and we are almost on time, 5 minutes late. But you conducted the session very well.
Thank you.
Thank you so much for
Thank you.
coming over.
Thank you so much.
Thank you.
And thank you for joining, and thank you everybody up to now. Be with us in the afternoon. It is more power-packed, 2:30 till 6:30. Thank you. Please give a big hand to all the speakers. Thank you.
Hello, dear ladies and gentlemen. It's my great pleasure to be with you.
Good afternoon. Welcome once again. It's really a hard session post-lunch always. And those who stay back, it shows their determination and zeal to attend. That's so nice of you to be here. The next session is on the miscellaneous topics of heart health. The session director is Dr. P.K. Gupta. Dr. P.K. Gupta, sir, is always been attending our SHAKEHEARTs from, this is now the 8th annual meeting, and he is also one of those about a handful of people who are attending not as just delegate, but as a faculty every year since the inception. So thank you very much. And he has flown all the way back from India with a great difficulty. But he has, and we are honored to have him as the session director of this session. Please welcome Dr. Gupta. Our co-chairs are Dr. Tamkeen, Dr. Muhammad Asmi, and Dr. Sunil Modi. He may be available online. So he said he will not be. Okay. So I leave that for you, Dr. Gupta. Thank you so much.
Good afternoon, ladies and gentlemen. Let me extend a warm welcome again for the post-lunch session. And Dr. Mittal has made our task a little difficult, providing a very sumptuous lunch. And you all must be feeling sleepy. But we would try our best to keep all of you awake. We have got a very exciting session. Which covers various topics from environmental pollution to the non-statin therapies to the imaging modalities of CAC and coronary CT angio, and of course the sympathetic overdrive and beta blockers. How these various things affect our heart, we are going to discuss in next 45 to 60 minutes. So I would request my co-panelists to start the proceedings for this session.
Thank you, Dr. Gupta. Dr. Gupta is going to talk about a very interesting topic, and this topic is how does environmental pollution affect the heart? My first question to Dr. Gupta is, why did you select this topic?
All right.
Sorry. Will you just let us all know what is your format of the session?
Right. So the first lecture, instead of going through all the slides, it would be in the form of question answer session. My co-panelist, he will ask the question and I will answer it. That's the way we are going for this lecture. So he has asked me, why did you select this topic? Right. So let me answer this. We all know that the cardiovascular disease is the leading cause of global mortality, more so in lower and middle income countries. And in CVD mortality, it is the ischemic heart disease mortality which contributes the most. And if you go through the beyond traditional risk factors for ischemic heart disease, there are 3 exposomes which has been identified. One is the infectious disease, and there is the mental health disorders, and third is the environmental pollution. And we all know that environmental pollution could be air pollution, light pollution, sound pollution, soil pollution, and water pollution. Out of all this, the air pollution has been most studied. So I'm going to just concentrate on air pollution. And this is happening because of the rapid industrialization, urbanization, agricultural practices, as well as deforestation, which has led to forest fires along with the sandstorms. And if you go through this, here are the risk factors listed for all-cause mortality across the globe. And you see here, air pollution is at number 4, much beyond obesity, diabetes, and dyslipidemia. We talk hours and hours together about these diseases. Air pollution causes much more deaths than these diseases. 9 million deaths globally happening because of the air pollution. Just giving you an example, in Delhi, during the hazardous air pollution, the risk of a non-smoker individual is equal to a person who smokes 40 cigarettes a day. Such a contribution of air pollution to the severe risk. So it is grossly underestimated, grossly under-discussed cardiovascular risk factor. And that's why I selected this topic to have more awareness among the healthcare professionals and general public at large.
You know, there has been so many debates whether it's affecting for many years until this occurred.
Right. So how it affects our heart, we all know air pollution is nothing but when the indoor and outdoor atmosphere is changed by chemical, physical, or the biological agents, leading to the change in the natural characteristics of atmospheric environment. And air pollution has got a lot of air pollutants in the form of particulate matter, the gases in the form of ozone, carbon monoxide, nitrous oxide, and sulfur dioxide, along with the multiple chemicals. Just particulate matters produced by sandstorm, dust, industries, fossil fuel burning, and all that. Depending upon the aerodynamic diameters of these particular matters, if it is 2.5 to 10 micrometers, it is called coarse. 0.1 to 2.5, it is called fine. And less than 0.1, it is called ultrafine. So these particulate matters, along with these, causes air pollution. Now, these are the various air pollutants which are included in the air quality index, because it's very easy to say that the air is polluted, but how to define it? So everywhere in the city, you will find that AQI of this area is this much. What is AQI? So in AQI, these are the pollutants, PM10, PM2.5, along with these gases and lead. The average 24-hour of these air pollutants is measured and compared with the laying down standards of that particular area. And on that basis, we classify the air pollution. If it is 0 to 50, it is good. But if it reaches beyond 300, it becomes hazardous. And if it is beyond 500, it becomes very hazardous. When these air pollutants come in contact with us, either through mucous membrane or dermal contact, ingestion, inhalation, or intrauterine exposure, it leads to pulmonary inflammation, systemic inflammation, autonomic dysfunction, hypothalamic pituitary adrenal axis activation, thrombotic activation pathways, ultimately leading to endothelial dysfunction, oxidative stress, platelet activation, cellular signaling dysfunction, and epigenetic changes. All these intermediary mechanisms ultimately lead to cardiometabolic disease.
So what are its consequences?
Right. So we have to understand how it is affecting our heart. Ultimately, what are the consequences of it? So short-term exposure of days and weeks can lead to rise in blood pressure, acute coronary syndromes, stroke, heart failure hospitalizations, as well as atrial and ventricular arrhythmias, especially atrial fibrillation. Chronic long-term exposure can lead to subclinical disease in the form of left ventricular hypertrophy, increased carotid intermedial thickness, increased coronary artery calcification, as well as the increased abdominal aortic calcification. Long-term exposure can lead to the ischemic heart disease, stroke, heart failure, abdominal aortic aneurysms, and increased mortality. So this is the central illustration which explains everything. And if you see, we have already discussed up to the cardiometabolic disease, which leads to hypertension, diabetes, dyslipidemia, atherosclerosis, plaque rupture, and thrombosis, leading to the adverse cardiovascular outcomes in the form of myocardial infarction, arrhythmias, heart failure, abdominal aortic aneurysm, and increased mortality.
I know it's very difficult to prevent or avoid pollution. You can't
That's
change
right.
your house, you can't change the road you go on every day. But
Yes.
what
it
can
is-
we do
Yeah.
to lessen this, to make it less,
Right.
just to make it less?
So that's the most pertinent question, and it's not easy to answer. So whenever we are exposed to the air pollution, we have to take measures at the individual level and at the population level. At individual level, if you are having an underlying cardiovascular disease, or you are at high risk of cardiovascular disease, having multiple risk factors, you have to take the personal measures in which you have to monitor the air pollution levels, avoid highly polluted areas, stay indoors, take care of yourself by maintaining healthy lifestyle, use air filters. If you are going outside, then use N95 mask, avoid air polluted areas, exercise in those areas who are away from polluted areas, having green belts as well as walking corridors. So these are and the most important thing is, if you have got an underlying CVD, be in touch with your doctors, because there's a risk of exacerbation. So you need a close monitoring and adjustment of your drugs. At population level, these are the ESC recommendations. Transition from fossil fuels to renewable energy sources such as the wind, tidal, geothermal, and solar. And all governments, they are trying to achieve, you heard a lot about it, trying to achieve and shifting from fossil fuels to renewable energies. Transportation reforms, promoting the use of low or zero emission vehicles. Again, a movement is going on in that direction. And avoiding the traffic in the city center areas. The use of diesel particle traps and catalytic converters, or use of alternative fuels as natural gas and electric cars. And again, the governments are taking steps to promote the electric cars so they can reduce the fossil fuel utilization. Urban landscape reforms, they are badly needed, that in communities, during the residential colonies, the industry should not be mixed. Industry should be away from the periphery, and residential colonies should have green belts and walking corridors, so you have less air pollution. So these are the few measures which can be taken at population level. Regarding guidelines, we have got class 1C recommendation. These are from the ESC 2021 preventive CVD guidelines, that we should take all measures to prevent air pollution, to decrease CVD, morbidity, and mortality. Those who have got underlying CVD should avoid exposure to air pollution to have exacerbation. And these are the 2023 chronic coronary disease guidelines of ACC-AHA. Again, they recommend those who have got underlying disease should avoid. Now it has been upgraded to class 2A.
So what are the take-home messages for the audience?
So, ladies and gentlemen, I will emphasize pollution is emerging and important, but underestimated and under-discussed modifiable CV risk factor. Air pollution is the most important environmental cardiovascular risk factor, with the PM 2.5 has been most studied. The various pollutants, despite different physiological and biophysiological characteristics, lead to CVD through common pathophysiological pathways, primarily promoting oxidative stress, inflammation, autonomic dysfunction, and atherothrombosis. Both short-term and long-term exposure to air pollutants can increase CVD-related morbidity and mortality, often acting synergistically with other CVD risk factors. Clinicians should incorporate air quality considerations when assessing cardiovascular risk. This is the thing which nobody does. Now it has to be kept in mind. So this is the last slide. I will finish off with these take-home messages. More awareness to be created among healthcare professionals and general public, and this interaction is in that direction. During acute exposure to hazardous air pollutant, known CVD and risk factors needs close monitoring and adjustment of therapy to avoid rise in blood pressure, ACS, stroke, atrial fibrillation, and hospitalization for heart failure. During CV risk assessment, the place of residence and AQI has to be considered. Urgent personal and governmental policy measures are to be implemented to prevent CVD risk caused by air pollution. More research and guidelines are the need of hour in this area. So, ladies and gentlemen, I hope that I am able to convince you whenever you do the cardiovascular risk assessment, consider air pollution as a CVD risk factor. And advocate your patients, those who have got underlying CVD and living in those areas, needs more close monitoring and adjustment of drugs. Thanks for your kind attention and thank you.
Thank you very much, Professor Gupta. We have Dr. Sunil Modi. He has joined us virtually. Dr. Modi, do you have any comments?
Yes, no, I just appreciate Dr. Gupta's effort, in bringing these unusual topics into our notice. And I also appreciate Dr. Brajesh Mittal's effort of including, these kind of topics, which of course are not so much explored and will have to, work a lot on the guidelines and on the measures or the strategies to improve these risk factors. I'll just thank both of them and then go on to next topic, Dr. Virendra Mishra, who has been a very, very long-term colleague from our college days and now, of course, in UAE for a long time, who is going to tell us non-statin therapies. What else in our armamentarium? A lot now. We've got a lot of new things for you to tell us, to discuss in this small 12 minutes talk. Viren, please.
So after air pollution, we are moving to the dyslipidemia, then to imaging, and then to sympathetic overdrive and beta blockers.
Good afternoon. I would like to thank Dr. Brajesh for organizing such a wonderful and educational conference and inviting us to share some thoughts about the non-statin and what else in our armamentarium. Everybody is worried of the statin these days. So let us see what is the problem. The problem is that still 17.9 million people are dying of cardiovascular disease as discussed in the morning. And one of the major cause of this is the cholesterol, very high cholesterol. And a lot of
people are not able to achieve this target of their cholesterol based on their primary or secondary prevention. So what to do to achieve this? And they say that somebody getting muscle pain, back pain, they say, no, I don't want a statin. There is a group of people also targeting a statin by WhatsApp, media, that statin can cause this, statin can cause that. So there is a lot of things which we can talk about non-statins. So what we can achieve by non-statin, if you see carefully here, in my early 50s, nicotine acid came, and then it was probably was reserved for selective cases. Same with the fibrates like clofibrate, fenofibrate, gymfibrogel in a selective indication. It's not can control your lipid profile aggressively. However, there is a lot of things has come up which we'll take one by one. Sterols, stenols, ezetimibe, bempedoic acid, PCSK9, inclisiran, and this is interfering messenger RNA, as well as the newer research on ecosipent which is called Vasepa, as well as probiotic, especially Belavi, cholesterol. We're going to take one by one. So as all of you know, and we know that we have an exogenous pathway, endogenous pathway to control our lipid and the production of LDL. 80% of our LDL, HDL, VLDL is produced from liver, not from the food. Food is responsible only 15 to 20%. So when we say, okay, I will control my lifestyle, I will control this, I will be able to control it, it's just contributing 15 to 20%. Rest is genes. How is your liver is made? Genetically, your liver is producing it. And that is one of the basic reasons why we are not able to achieve the target with simple lifestyle and control. Ezetimibe works majorly on exogenous pathway. Other drugs, we will take one by one control on this. So let us take the ezetimibe. It inhibits the Niemann-Pick C1-like 1 receptor activity. By reducing the Niemann-Pick C1-like 1, it causes the cholesterol transport from the gut to the liver and it's blocked. So it is not reaching to the liver, increase the LDL receptor expression, thereby controlling the LDL in circulating by clearing by the LDL receptors. There are many publication has come in support of the benefit of ezetimibe like SEAS trial, SHARP trial, and Improve It. Especially the Improve It has shown significant improvement in all-cause mortality, cardiovascular mortality, acute myocardial infarction, stroke, unstable angina, or revascularization. This is much beneficial when we combine ezetimibe with the statin rather giving statin alone. Come to the bempedoic acid. Bempedoic acid is a newer molecule, almost is going to go as effective as a statin because if you look at the mechanism, it is working, it's a prodrug. So it changed from prodrug to the active drug, which is active metabolize, and this active metabolize inhibit ATP citrate lyase. And ATP citrate lyase, if you see the mechanism there just before the statin where HMG-CoA is affecting the statin, it works before that. So it is inhibiting this de novo production of cholesterol in the liver. And it has shown a significant improvement by many of these trials like Harmony trial, Wisdom trial, Serenity, Tranquility, and Outcome. The latest is Outcome, which just came last year, has shown significant. It's a 13,970 patients, randomized half of them in a bempedoic acid, half in the placebo. And see the benefit. All-cause mortality, MACE is reduction, fatal, non-fatal myocardial infarction has been reduced significantly, coronary revascularization has been recruited. So outcome trial giving an outcome benefit with this is going to be the molecule very soon. PCSK9 inhibitors. This is again another non-statin, which is very effectively controlling your lipid and LDL. FDA has approved aleucrumab, which is a preluent, as well as aleucrumab Repatha for the use. And as we know that aleucrumab or these molecules is working by blocking the PCSK9. PCSK9 attack the receptor and destroying the LDL receptor. So once it is blocked by these antibodies, lot of LDL receptors are available, which is taking all the circulating LDL from the circulation and bringing it back to the liver for metabolism, thereby decreasing significantly LDL. So a single use by these antibodies has shown significant reduction in cholesterol. Here is a 4-year and 4-year open label extension, where this is an outcome trial. It has shown significant reduction in cardiovascular mortality, myocardial infarction, stroke, and coronary revascularization beyond even 5 years or 7 years. If you see, the curve is keep on separating. So the benefit is a constant and continuous. This is very interesting. MK0616. This is a molecule of 2023, has been labeled as a molecule of 2023. It is an oral PCSK9 inhibitor. And the phase 1 trial and the phase 2 trial has significantly shown the benefit of it, reducing in cholesterol and LDL cholesterol. MSD is marketing this molecule and is in the phase 3 trial by the name of Coral Reef. 17,000 patients has been recruited over globally. The study is going on. Probably study will be available very soon next year. Going to be a game changer. Inclisiran is a small interfering RNA. And from Orion 1 to Orion 18, there is a lot of studies being done to show the benefit, safety, dose, and there is an outcome in population. It has shown a single injection can reduce up to 40% LDL in your body. The benefit of this can be given 2 times in a year, once in a 6 months. And it can reduce anything from 40 to 60% of LDL with a success rate and outcome. Future of the PCSK9. It's already in pipeline. Gene silencing. So antiserine oligonucleotide by CRISPR gene editing as well as VER101 to silence the gene through the working through PCSK9. This is indirectly reducing the cholesterol. Will be available very soon. Vaccination is again virus-like peptide is already in a study, VLP, to find out the benefit of vaccine giving to control the PCSK9 and get the benefit. Naturally alkaline berberine, which is again inhibit the transcription of PCSK9 gene, which is available over the counter, had shown significant response. Coming to newer version of icosapent, which is a Vascepa, we know that triglyceride is independent risk factor. Higher the triglyceride, more worse it is. If it is high, 25%, 50%, it can increase non-fatal MI, cardiovascular death, hospitalization, or unstable angina, whether it is a Framingham trial or it is a miracle trial. Higher the triglyceride is worse for us as a cardiovascular outcome. And icosapent or Vascepa has worked by improving the endothelial function, improving the nitric oxide production, anti-inflammatory effect, as well as plaque stabilization by reducing thrombosis and myocardial infarction. It has been proved in a reduced revascularization trial, where when Vascepa is used in compared to the placebo, has reduced the RR from 16.7 to 11.4 with a significant p-value 0.00000008, which is very, very significant. In Evaporate trial, which is an imaging trial, which is one of the very good trial where they have imaged the plaque intracoronary, and these plaque, once Vascepa given in as early as 1.5 years, 18 months, has shown reduction in the plaque, improving in the fibrofatty, improving in the non-calcific plaque reduction and attenuation. So imaging trial successfully has shown benefit of Evaporate. Let us come to the probiotic. There is a lot of talk about the probiotic, which is improving our gut, through gut improving the lipid profile. So Bellamy cholesterol very ingeniously taken the 5 probiotic, which is a Bacillus coagulans, 4 lactobacillus, prebiotic inulin, and stenols as a phytosterols, combining all as a single probiotic and use that. They work by deconjugation, bile salts and the bile salt hydrolase, and by binding the cholesterol to prebiotic cellular surface. By this reducing the LDL, Bacillus coagulans alone has been shown to reduce cholesterol by 39 to 49%. Other lactobacillus has shown whether it is any of the acidophilus, gasseri, plantrum, or reuteri from 8 to 34%. Inulin is a prebiotic which has shown just 1 minute. Inulin has a prebiotic which has decreased the gene expression of hepatic enzyme responsible for de novo synthesis. And this has shown significant improvement. When they mix this inulin to your pasta, soya milk and pasta, and did the study just 4 to 6 weeks, they found the total cholesterol reduced by 22 to 23%, and LDL has improved to 35% in just over 2 months' time. So it has shown significant improvement. Sterol and phytosterol is structurally similar to as a cholesterol. And because they are similar, they compete the cholesterol at absorption site, thereby they reducing their cholesterol and LDL by 10 to 14%. And when we combine all these in one pill, like 5 probiotics plus inulin plus sterol and phytonadione, they have shown significant improvement in controlling lipid profile and thereby outcome. These things is already in use and showing a good road to control of the cholesterol. So in conclusion, ladies and gentlemen, we have a huge armamentarium apart from statin. We can use many drugs. If it is a secondary outcome, we need to be strong. We can use PCSK9 direct inhibitor as evolocumab or inclisiran, or we can combine ezetimibe with other drugs. And the newer molecule 0616, MK0616, is going to be in pipeline as a game changer. Bempedoic acid as a clear outcome has already shown a great promise and is going to be available very soon. Clinical trial of reduce it or evaporate, which is done by ecosapent ethyl, has shown a great outcome, a road of success. Combining sterol, stenol, and probiotic as a single pill Belavi cholesterol tablet has also shown significant reduction in your lipid profile and outcome. Thank you.
Thanks, Dr. Mishra, for covering the whole spectrum of the non-statin therapies, so enlightening us. So don't get stuck when you have got a statin tolerance. He has given you a lot of alternatives. We will take questions at the end. So let's move on to the...
Dr. Gupta, if I can just make a 2 lines comment, because actually I have to leave the webinar shortly. You know, the statins are the most effective drugs. Everybody will agree. All of you will agree. I have changed the way I practice in last about 10 to 12 years. I don't tell the patient that I'm giving you a cholesterol medicine. I tell the patient I'm giving you this medicine so that you don't get a second heart attack. You don't need angioplasty, you don't need a bypass surgery, and you don't die suddenly. Yes, it also reduces cholesterol, but that's not the main reason I'm giving you. Believe me, for last 10, 12 years, particularly my medical colleagues, you know, the orthopedicians, gynecologists who really need statins, everybody used to complain of leg pains and this pain and that pain. They have stopped complaining of all those pains. Once I tell them that we are not trying to reduce the cholesterol, yes, it will reduce cholesterol, but the main reason I'm giving you is this. So there is a lot of, you know, pseudo-statin intolerance, as we call it, which I just wanted to highlight. Of course, these newer drugs will be extremely useful in those who have true statin intolerance, but then that's how it, my comment was.
I just want to add one thing in this one. In this respect of Dr. Sunil Modi's query, I am currently doing one research about the genetic analysis of all those patients who is on a statin. I have recruited already more than 500 patients in this genetic analysis. We collect the sample, send this sample to the genetic lab to Alain, UAE University in Alain. The genetic department and their Professor Basim, he's analyzing it and sending the result back to us. To our surprise, these are coded like mild variation, moderate variation, severe variation. We already have a lot of patients with the severe variation genetically deficient in the enzyme, in the SNPs deficient in them, which metabolize these drugs. And the moment I give them that drug, they have a severe reaction with the statin. We are going to publish this very soon, within a year, because we are now compiling these studies data. They are actually genetically people where they can have severe reaction, but we don't know unless we do the test. So it is there that there are some pseudo, but there is.
Thanks, Dr. Mishra. And we will move on to the next lecture. And it's the coronary calcium and CT angio screening and beyond, would be presented by Dr. Rami Niamtullah. He is the Medical Director, Cardiovascular Imaging Specialist, Allied Medical Center, Dubai. Dr. Rami.
Thank you, Dr. Gupta. Good afternoon, everyone. Thank you, Dr. Mittal, for the invitation, for all the efforts you do for this conference, and the respected chairman. So I'm going to try to be as much as possible practical. I'm going to expose a question, and then I'll try to answer it, and then I'll ask for the input from the chairman. How does this function? Excellent. Okay, so first, I know many of you has heard of it. Maybe you use it, or you ask for it, or you even interpret it. But I think also there's a lot who don't know exactly how to interpret a coronary calcium score. And basically, it's counting the calcifications, which is the reflection of atherosclerosis on the heart arteries. So it's a quick scan. It takes seconds. It's a very low radiation, doesn't need any significant preparation, let's say. And then based on that, we calculate the score on the coronary arteries. And based on the score, if it's 0, it's normal. Okay, this is what we aim for. And then depending on the threshold that we get, we can say how much plaque burden, how much atherosclerosis on the coronary arteries we have, and we can put a risk category for this patient. So of course, 0 will be no plaque burden and very low risk. However, over 400, it's extensive plaques, high risk. And many studies consider these patients like secondary prevention, like having the same risk as patients who already have ischemic heart disease. And depending on the score also, we can guess what's the probability or what's the chance of having a heart attack or a heart blockage. So based on this, when you get a calcium scoring report, I think you need to have this in mind, or it needs to be attached to the report for you to interpret well the score. Now, what's very important also, the score is not the same for everyone. It's very different from a lady who is 45-year-old and a man who's 75-year-old. Okay, so we cannot interpret it the same for both. 100 is not the same. And this is just to show you, so that's why we talk about percentile. So we try to put each individual in his category of age and gender and ethnicity, where he compares to his peers. So taking, for example, a calcium score of 200 in a 60-year-old man who is Caucasian, he was in the 58th percentile. So his risk is very moderate. However, having the same calcium score in a lady of the same age and same ethnicity, just changing the gender, puts the lady at the 89th percentile. 89th percentile, it's high risk. It's almost very high risk. 90th percentile is very high risk. So we always need to keep this in mind. The same calcium score in a man aged 75 puts him at 29%, which is very moderate, almost low risk. So it's always important in your calcium scoring report not to have only an absolute value, but also to have a percentile to be able to interpret it properly. Now, of course, the screening, when to use the coronary calcium score, and this is where is a confusion. The confusion lies, because if you ask me also, I will have like, okay, probably this and this and that. And why is this? Because every scientific society, every national society decided to have their own screening guidelines. And if one nice study tried to really put everything, all the data on the calcium score, it was published last year. in JAK imaging 2023, and then they put all the scientific societies and by country and by scientific society, the different guidelines and when to do it, what to do it, when to repeat it. So of course you can go through this paper, but there are some common indications that all the guidelines agree on. The age basically is more than 40 years, so we should take above 40-year-old to start screening with calcium score, and usually up to 75. The risk group that would benefit most from a calcium score is the intermediate risk group, so it depends on also definitions. Most of them go by 75 to 20%, some of them 5 to 20%. So again, there is some discrepancies, but this is very clear, intermediate. And finally, we are talking about screening here. We are talking about asymptomatic population, okay? So no symptoms, and this is the patients that would benefit. So what's the test threshold? What's the treatment threshold based on the calcium score? The calcium score is used basically to downgrade or to upgrade the risk. So these patients at intermediate risk, based on the calcium score, you would downgrade them if the score is 0, for example. And a patient who required statin, you can basically withhold statin now for them. And a patient who was considered intermediate and suddenly had a calcium score of 300 or 400, this is not intermediate, this is high risk and need not even statin, but initiate and consider statin and sometimes high dose statins. Still, there are non-agreement points on threshold for the use of aspirin use, for aspirin or antihypertensive drugs. Some societies say above 100, sometimes they say above 400, we should use aspirin. There is still discrepancies related to that. So I think this is the most important slide, I think, regarding the calcium score, which patient would benefit. And basically it's to initiate those preventive therapies and mostly to initiate the statin to decide whether we should do it or not. Sometimes a patient refuses the statin. So for you to know whether I should do it, even if it's outside the intermediate group, then you would do a calcium score to decide, okay, you have a lot of plaques, we need the statin. You don't have plaques, okay, I'm okay with you not to stop the statin. So this is pretty much how statins are used. Okay, that's going fast. Okay, there are a lot of calculators online that can, from the score, give you basically, if you want the percentile, but also the arterial age of the patient, which could be also interesting to motivate your patients. So this guideline actually not only says what's in common, but also it helps us practically make these personalized decisions per patient, because this is what I think about medicine. Medicine is going to become more precise and more personalized for each patient. And finally, to finish with the calcium score in symptomatic patients. We were talking about screening only. Now, does the calcium score have a role in symptomatic patient? Well, again, we know that a 0 score, okay, practically exclude coronary atherosclerosis in subjects with low pretest probability. And even with patients that are symptomatic, and if you take everyone, okay, when you get a zero calcium score, the probability of having a significant blockage is less than 5%. Many studies have happened. This one found 4.4. Many studies can tell us that the negative predictive value of a 0 score is 5%. So 95% we can rule it out. So definitely calcium score can be used in some cases when we are talking about patients with chest pain. And even in the guidelines of the American College of Cardiology and AHA, when we're talking about stable chest pain, no known coronary artery disease, this low risk category, where they recommended not to do any testing, but if you want to be more, let's say, about having more arguments whether we really should be worried about this patient, calcium score or exercise stress test are both a 2A indication. Okay, so it can comfort your diagnosis by not do the testing, or if you get a lot of results, a lot of calcium, then you should do it. So any comments from the speakers, the chairman?
I think the coronary calcium score in India is widely utilized right now. And I have got a data of more than 500 patients of coronary calcium score just in 3 months We screened the population in less than 100 dirhams, and we have got data of 500 patients. And variety of, I have seen coronary calcium score 0 with a patient of MI, with a patient who is post PCI. The reason being, as he has highlighted, you just not remember the absolute numbers. You have to go through the percentiles, because we have got the young MIs in 20s and 30s where the calcium has still not deposited. We have got a lot of soft plaques which gets ruptured and produce MI. So that's the comment. Move ahead.
Okay, so we're gonna talk very quickly about CTCA this time. So CTCA, of course, today it's not in the guidelines for non-symptomatic people for only screening. It's mostly for symptomatic people, chest pain. And whenever you have an intermediate to high risk group, patient with no known coronary artery disease, I think CTCA pretty much in the AHA-ACC guidelines got the first recommendation of 1A to use the CTCA because it's effective for diagnosis, risk stratification, and guiding treatment decision. While all the stress imaging was a 1B and the exercise stress test was downgraded to a 2A indication. So CT definitely, symptomatic people, intermediate risk is very good. So when to use CT, when to use imaging, first, please look at the image quality that you suppose you're gonna get from the study and the expertise, the local expertise that you have in your center or in your city. But also, patients that are younger tends to favor better to the CTCA. When you suspect less obstructive coronary artery disease, CTCA. If you want to see the plaques, go for CTCA, while if you have more elderly patient, more suspected obstructive coronary artery disease, then there is indication of the ischemia studies, okay? And this is just to show you how good the CT is, not only to show the calcified plaque, but also the mixed plaque. And by showing the vulnerable plaque, this is a very big plaque with some lumen, spotty calcification, hypoattenuation in the center, very big positive remodeling, even though this plaque will probably end up being a 50% or 60%, a moderate plaque. This is a very vulnerable plaque, and this is the plaque that basically will cause 20% more, 20 times more than the calcification alone, myocardial infarction. Of course, having also the FFRCT adds to the I think the interest of CT in this kind of patients. So since the time I think is finished.
You can go ahead.
Okay, fair enough. So are all these CTs the same? Also, this is important. Some places you have a CT in less than 1 second, 512 slides. Sometimes you have the CT done on 64 detector. Are all of them the same? Of course, the image quality is much better when you have better, faster systems, newer systems, and more detectors. And many studies have shown a difference of 10% in the diagnostic accuracy when you use high-end CT compared to lower-end CTs. Finally, is there a place for CT when there is a patient with stable chest pain and known coronary artery disease? Actually, the recommendation for CT is less in this case. In this case, it's either we go to invasive angiography or to ischemia study. Only when it's non-obstructive coronary artery disease, patient had before an angio or a CT saying less than 50% stenosis, then CT could be an option, but it's only a 2A indication, while angiography and ischemia studies are in level 1 indication. And then also the stress imaging studies are not all the same. Looking at the sensitivity and the specificity of the different ones, you can, for yourself, realize that even though all of them are in the same batch with the guidelines, but not all of them basically give us the same accuracy for the patient. Thank you for your listening. If you have any questions.
Yeah.
Just quick about FFR. Has it been, because it's very important for us now to define where to go to, dilate or not dilate. Has it been now a routine practice here? And are you doing it here, or are you sending the information outside to be in the States or whatever?
Well, the FFRCT, I think, is a very interesting option because it does pretty much what the invasive FFR does, but without having to do any invasive procedure, without having to scan the patient again. So on your CT data set, you can apply this FFR. Finally, this year, we're starting to get, because of the AI being more and more incorporated, solutions that can be done inside. We don't need to send the images to the US, to HeartFlow or other companies. We can get the software. It costs some money, of course, but we can get the software and then give our patients that do have plaques between 40 and 70, 80%, so the intermediate plaques on CT, give them the FFR, which will give us an answer which is between CT and FFR, 90% plus correlated with the invasive FFR, which is today's gold standard. The only limitation that we have in this case, FFR CT does not work on any data set. The CT needs to be perfect. You cannot have motion artifacts. You cannot have step artifacts on a CT and then go and do an FFR CT. It will not work. So pretty much today, it can only be used on the very high-end systems that get us homogeneous image quality and really crystal clear image quality to be accurate.
Thanks, Dr. Rami, for explaining both the imaging modalities and their role, and we will move on to the last lecture of this session. And that would be online. Dr. Peter could not join us. He is going to talk on heart in overdrive, sympathetic activity and role of beta blockers. We are all familiar with Dr. Peter Ostovic. He is professor of medicine, Belgrade University Medical School, Serbia. Dr. Peter. Okay.
Hello, everyone. I'm really sorry that I was not able to join in person due to air traffic disruptions, but I'll do my best and try to give you a lecture online. So the topic of my lecture is heart in overdrive, sympathetic activity and role of beta blockers. So it is well known that sympathetic activation occurs and contributes to a number of diseases, including congestive heart failure, myocardial infarction, arteriogenesis, arrhythmias, and hypertension. There are a number of markers how we can access the activation of sympathetic nervous system in clinical practice. Currently, we most often use the levels of plasma norepinephrine, then microneurography, including muscle sympathetic nerve activity. And what I personally really use most frequently in my routine clinical workup is blood pressure and heart rate variability. So this is a scheme where we can appreciate that obesity, insulin resistance, obstructive sleep apnea, among other factors, can contribute to sympathetic nervous system activation as well as activation of other systems, which in turn can lead to changes in kidney function with increased sodium reabsorption, then to blood vessel vasoconstriction with consecutive increase in peripheral vascular resistance, and negative impact on the cardiac muscle with increased cardiac output. These changes can lead to hypertension, endothelial dysfunction, arterial stiffness, and left ventricular hypertrophy, which further can lead to target organ damage, which can result in chronic kidney damage, atherosclerosis, heart failure, occurrence of major adverse cardiac events, and definitely premature mortality. So when we look at the patients with congestive heart failure, we can see that sympathetic system activation is evident in a number of organs, including kidney, liver, and muscle, but it is far more pronounced in the heart. So when we look at the markers of the activation, we can see that patients with congestive heart failure have increased levels of plasma norepinephrine, increased levels of norepinephrine spillover to plasma, and reduced clearance of norepinephrine. When we look at the muscle sympathetic nerve activity, we can see that this activity is also increased in patients with congestive heart failure, and that this increase is more pronounced in patients who are more symptomatic, like patients in NIH class 3 and 4, as compared to patients in NIH class 1 and 2. So clinically, the marker of increased sympathetic nervous system activity in patients with heart failure is definitely heart rate above the 70 beats per minute, which indicates that we should increase the dosage or introduce new sympathy inhibitory drugs. As you can see on the right-hand side panel, the heart rate is higher in patients with higher muscle sympathetic nerve activity, whether it is measured in outpatient department or by 24 hours ECG Holter monitoring, as well as in patients who have higher plasma norepinephrine levels. So these findings indicate that patients with higher levels of sympathetic nerve activation definitely have higher heart rate at baseline than patients with decreased sympathetic nerve system activation. So now let's turn to patients with hypertension. We can also appreciate that sympathetic nervous system activity is increased in patients with hypertension. And the more severe the hypertension, this activity is more pronouncedly increased, as we can see on this left-hand panel, in which we can see that patients with severe hypertension have more increase in sympathetic nerve activity than patients with moderate hypertension. The same holds true for patients with white coat hypertension and mass hypertension, and definitely for patients who are reverse and who has reverse and non-lipid profile on a 24-hour Holter BP monitoring. Now let's switch gears and see how we can counteract these deleterious effects of sympathetic nervous system. Of course, beta blockers are the mainstay of the therapy. And on this slide, we can see what is the effect of beta blockers in patients with coronary artery disease and heart failure based on their ejection fraction. You can appreciate that patients with heart failure with reduced ejection fraction have favorable answer to beta blocker therapy in terms of reduction in all-cause mortality, cardiovascular death, cardiovascular hospitalization, as well as in cardiovascular death and hospitalization. Whereas patients with heart failure with mildly reduced ejection fraction, that is, patients with ejection fractions between 40 and 49%, have reduction in all-cause mortality and cardiovascular death, but no real impact on a cardiovascular hospitalization incidence. On the other hand, patients with HFpEF appears to have no beneficial effects from beta block therapy, since there are no changes. I mean, there's no difference between these mortality and morbidity parameters versus placebo patient. Of course, we should note that the number of patients with HFpEF is very small in this meta-analysis, only some 240 patients. So it is definite that the large beta blocker trials that were performed in the late 90s and early 2000s have shown that beta blockers, but not all beta blockers, can reduce all-cause mortality and hospitalization for patients with heart failure with reduced ejection fraction. So that holds true for metoprolol, carvedilol, and bisoprolol. When you look at nebivolol, we have only one trial that included elderly patients, and it has been shown that nebivolol can reduce all-cause mortality and cardiovascular hospitalization in patients who were taking nebivolol as compared to patients who were taking placebo. So having that in mind, it is not a surprise that beta blockers are one of the four pillars of management of patients with HFrEF among ACE inhibitors, MRAs, and SGLT2 inhibitors. The situation is somewhat more complex. It will look at the patients with preserved ejection fractions, and there are really no large-scale placebo-controlled trials in this group of patients. So beta blockers in this group of patients can reduce all-cause mortality, at least according to this meta-analysis, but have no impact on the reduction of incidence of hospitalization for heart failure. So when we look at the patients who had a myocardial infarction, who had stable coronary artery disease without primary myocardial infarction or left ventricular dysfunction, we can see that beta blockers, as compared to placebo, does not reduce major risk cardiac events, myocardial infarction, and cardiovascular death. This study has been presented recently at the American College of Cardiology annual scientific sessions at the beginning of April. And this particular study included patients with acute myocardial infarction who had undergone coronary angiography, but have LV ejection fraction of at least 50%. These patients were randomized to placebo or beta blockers and were followed for the primary endpoint that included composite of death from any cause or new myocardial infarction. As you can appreciate for this middle figure, there is no difference in patients who were taking beta blockers or placebo from this primary endpoint. When we look at the single endpoints, again, no difference in the occurrence of new myocardial infarction, of death from any cause. So therefore, the conclusion is that beta blockers are not having any favorable impact on this group of patients. So let's go for the hypertension. If we look at the meta-analysis, we can see that beta blockers against placebo have no impact on total mortality, have modest impact of the burden of total cardiovascular disease, then of coronary artery disease, but can reduce significantly total stroke. When we look at the adverse events, it appears that the incidence of adverse events that can lead to the withdrawal of the therapy are threefold increased in the group of patients who are taking beta blockers. Again, when we look at the meta-analysis that were looking on the impact of beta blockers against placebo, we can see that beta blockers can reduce systolic blood pressure by approximately 10 millimeters of mercury, diastolic by approximately 7 millimeters of mercury, and that beta blockers, when compared to placebo, can reduce the incidence of heart failure and stroke. But when we look at the meta-analysis of beta blockers versus all other drug classes for the treatment of hypertension, we can see that the impact of beta blockers are pretty similar in terms of reduction of blood pressure, and that beta blockers have neutral effects on the occurrence of congestive heart failure and cardiovascular death. So this led to the change of paradigm in the guidelines for the management of arterial hypertension that were published last year, when we can see that beta blockers are included as the first line of treatment among diuretics, calcium channel blockers, and ACE inhibitors, and are particularly advised to be used in patients with chronic coronary syndromes, post-myocardial infarction, HFrEF, atrial fibrillation, and women of childbearing potential. This is translated into somewhat different algorithm that is used for the treatment of hypertension, where ACE inhibitors, calcium channel blockers, and diuretics are still the mainstay of the treatment, but we can add beta blockers as monotherapy or at any step of combination therapy. So there is much more place for the beta blockers in the treatment of hypertension according to the new guidelines. So ladies and gentlemen, let me conclude that a lot of our patients are having increased sympathetic nervous activity, and that a lot of these patients can benefit from beta blockers in terms of the reduction of mortality and morbidity. Thank you.
Thank you, Dr. Peter, and we regret that you could not join in person with us. And if you are able to hear, thank you so much for your presentation and taking the efforts. Dr. Gupta, any last one comment you in between Dr. Peter, and then we conclude the session.
Yeah, we had a wonderful presentation from Dr. Peter covering the excessive sympathetic activity across the spectrum of cardiovascular disease, including hypertension, ischemic heart disease, and heart failure, and the current status of beta blockers in them. Thanks, Dr. Peter.
Thank you so much.
You're welcome.
Thank you.
Thanks for inviting me, and I really am sad that not be able to join us in person, but nevertheless, I hope that you had a fruitful symposium, and I hope that I'll be here next year.
Thank you. Thank you. I have one last line from my side about this session. I didn't plan this session this way, but somehow it became by the different topics when we collected, it became a wonderful session of very varied variety. Pollution to beta blockers, these are not very common topics we discuss every day, CT and calcium scoring, and then non-statin therapy. And all 4 lectures, I will believe, are excellent for everybody. Pure interventional lectures are useful for the intervention cardiologist, but these kinds of informations are very, very metaphoric for everybody. So thank you so much, all the speakers, for taking out this wonderful, wonderful session. Thank you.
Thanks, Dr. Mittal.
Thank you. We move forward. I have yet another wonderful session going to happen. And diabetes is now at everybody's tongue. Everybody's talk about not sugar but diabetes. It has become a very, very common menace, and it is our best friend and worst foe, I would say, for cardiologists. And this is the session dedicated to diabetes in many different ways. For this session, I invite Dr. Abdul Jabbar as a session director. He's professor by look as well as by conduct. So please welcome Dr. Abdul Jabbar. He's a wonderful friend, my colleague in the hospital next door. Thank you so much, and he will take you forward for this journey. Plus, please, 1 hour is the limit. Thank you, Dr. Jabbar.
I would invite, before we start the session, my colleague, friend, working with me, Dr. Salvin George, who will be chairing the session and will be introducing all the speakers, including myself. Dr. Salvin George, please come.
Good evening, everyone, and it's nice to see a lot of faces still very active. Thank you, Dr. Mittal. Thank you, Dr. Abdul Jabbar. So I'll be going ahead to introduce our speakers for the upcoming sessions, and this is non-cardiology. This is mainly diabetes. It's all it is all interconnected. So just a short deviation and some very, very interesting topics coming up. Especially I want to introduce Dr. Abdul Jabbar, who is the consultant internal medicine and endocrinologist for Medcare Hospital. We all know him so well. He's very famous for his work in diabetes and Ramadan. We all know that he's been responsible for all the guidelines that has come through. And he's going to give us something very, very interesting in the next few minutes. And that's about intermittent fasting. Common topic that we all think, we talk, a lot of patients ask us every day about this particular topic. So let's look in depth scientifically on what Dr. Abdul Jabbar is going to share. Is it a fad, fashion, or is it factual? Please, Dr. Abdul Jabbar, to the stage.
Thank you, Dr. Salvin. And as you are all thinking, just a 1-minute question. What do you think? It's fad, fashion, or fact? Fact. So moving forward, we discussed since morning the cardiology, but as we know, the mother of all problem is obesity and metabolic syndrome. And when we sit in the sessions, even on the dining table, people say our grandmothers and fathers eat everything. They never exercise. They never had heart problem. What was the problem? The simplistic way is they were eating to live, and we are living to eat. Right? Their feast were well balanced with their fast, culturally, traditionally, religiously. But our fast even are overcompensated by the feast. So that's why, as we say, we go to a car, drive to the gym, and bicycle. They used to bicycle from their home. So that is the thing, the culture and the lifestyle has changed, and that's the way it is working. So no interest, as you say, the fasting is deeply rooted in all our culture and religious atmospheres. because it is a highly conserved evolutionary process. It was built in the systems of the human beings as well as animals. And it elicits the cellular survival process that we don't eat, you become more energetic after a while, and your repair process starts, which repairs all the metabolic pathways in your body. But if you don't give enough time to starve or fast, you are going onto the wrong trajectory. It is an evolutionary perspective. So 3 meals per day was not prescribed by birth, by any religion, or by any convention. And most of the people in the days which we are talking about, they used to have 1 or 2 meals per day. Why? Because they didn't have enough. Not everybody had enough. But 3 meals per day came with industrialization. The food was available. It was easily to cook. It was easy to store. It was easy to refrigerate. And then we started, oh, I need 3 meals per day. But as we see, fasting is known to the human ancient traditions. And interestingly, it has also been known as healing method for the disease in the past. Hippocrates, the great modern science father, he used to wrote, to eat when you are sick is rather to feed your illness. So we used, our nature says somebody is very sick or ill, what they will do? They will stop eating. That's the natural response to elicit recovery. The ancient Greeks believed that fasting improves cognitive abilities. The ancient Greek Plutarch used to say, instead of using medicine, better fast today. And the final thing, Philip Ferrer says, fasting is the greatest remedy, the physician within. So with this background, we are now learning, and you'll be reading a lot and learning a lot, and many of you already been experiencing and practicing yourself the intermittent fasting. So I'll give you, because you're all doctors, some background of that. The potential health benefits, weight loss, everybody starts doing it for that, not for the health, for their weight loss. You want to look smart and beautiful, you don't want to be healthy. That's wrong, right? You want to be healthy, not only smart and beautiful. It lowers the risk of type 2 diabetes. In fact, in some of the data, it reverses type 2 diabetes as well if it is started early. It improves the heart health so that our patients don't go to them. It improves the brain health so that our patients don't go to the neurologist. So we are all who are dealing with the metabolic syndrome, diabetes, and obesity. Our prime objective is not to depend entirely on the medicine to get the results, but what can we do or our patients can do from within. And it's not very difficult, as you will learn from it. It has been shown, at least in some of the animal studies and human studies as well, that it reduces the risk of cancer, reduces Alzheimer's disease, induces cellular repair response, and improves longevity, which is well proven in animals, but not in human beings so far, because nobody has fasted for so many years. So we don't know whether it improves longevity or not. So intermittent fasting has got 2 possible pathophysiological mechanisms. And that's where the concept derives. And that's where, as doctors, we learn why is it happening to give us the improvement. So the most important thing is, it is not a diet that I'm doing a keto diet, I'm doing a Mediterranean diet, I'm giving a low-fat diet. No, it's just an eating pattern based on the traditional method of I fast for so many hours and I eat in so many hours. It's not telling you what to eat, what not to eat. It's just telling you the timings when you should eat. So the first important thing about it is related to the innate circadian rhythm, which is in the central system. Which gland is circadian rhythm? Pineal gland, right? But we still don't know what it's doing, right? Because pineal gland, and that's the central system. But the new pathology molecule is suggesting there is an external circadian rhythm as well, which is in the liver and the gut, and which is dependent on when we eat. This one depends much more on when we sleep and wake up. This is when we eat and stop eating. So this connection, when it is in a 24-hour time period, is driving force behind the coordinating a balance between the anabolic and catabolic process. And we all know when we sleep, the growth hormone comes high. When we wake up, the cortisol comes up. the norepinephrine comes up. All these things are circadian rhythm controlled by that. But if you disallow the circadian rhythm with the peripheral mechanism to work, there is a conflict. And that's where it is something like you eat and you stimulate insulin release, the maximum release happening at the dinner time. Totally wrong compared to the innate circadian rhythm. So in the daily fat fast cycle, it is important for maintaining the balance between messenger RNA and a protein, which controls the multiple aspects of our metabolism, including glycolysis, protein synthesis, lipid synthesis, and oxidation. The second aspect about it is what we call is intermittent fasting leads to a metabolic switch. It's the leverage circadian biology to improve metabolic health. It plays a role on the hormone secretion patterns, physical coordination, and sleep. And the clock oscillators have been found in the peripheral tissues as well. And desynchronization has an important aspect on the metabolic well-being of the human being as well as any organism. So it has been shown that it shifts the work, disrupts the circadian rhythm, and is increased risk of obesity, diabetes, cardiovascular disease, and cancer, particularly breast cancer. Gastric emptying and blood flow are greater during the daytime than at the night, but we are giving them more food at night time. The chronically disturbed circadian rhythm has problem. And moving forward to the next one, as you can see here, you can see the wake feeding cycle. You can see the highest rate of myocardial infarction happens in the morning, highest testosterone secretion in the morning, melatonin secretion drops in the morning, rise in blood pressure in the morning, and highest probability of death in the morning. What happens during the night? The lowest body temperature, melatonin secretion starts, menopause host pressures, cholesterol synthesis, and this circadian rhythm has a coordination, and if it is not displacing at the correct time, it will have got impact. The second part, which has come from the industrialization and the carb, so many of the carb eating coming up, is the metabolic switch. You are giving more and more carbs, you are switching more and more insulin release, and you are not giving a break to the insulin release, and insulin release will not produce you diabetes. The first thing it will produce is more insulin resistant, more weight gain, more central adiposity, more tummy fat, and more insulin resistant till you get diabetes. So this fast feed cycle, if it is appropriately managed, it will give a dependence on the glucose drive from the liver during the typical eating to ketone-derived adipose cycles. And this metabolic switch can improve the glucose regulation, reduce inflammation, and increase autophagy, which removes the damaged molecules to prevent against further metabolic stress and can reduce oxidative stress as well. So intermittent fasting can lead to weight loss and other health benefits, at least in the short term. So these are again showing us the same thing in the mapping graph, and you can see what is happening. It is improving the glycogen depletion, leading to the fat mass, preservation of the muscle mass, and at the same time, the neuron improvement, free fatty acid circulation, and everything. The physiology of fasting is, again, many of the people, as I see and the people talk about it, they are doing intermittent fasting, but many of you will be doing it. What time they do the intermittent fasting? They start 2 p.m. and they take their last meal 10 p.m. They say it's an 8-hour fast. Again, it's against the circadian rhythm. That's why you don't get the best advantage. The important time is you start eating in the morning when everything in your metabolism is going up. Your growth hormone is going up, your cortisol is going up, your insulin is going up, your testosterone is going up, and then you stop eating around 3, 4, or 5. That's the time when the evening time starts in the innate circadian rhythm. So this data also has shown that the fasting ketones become the main source of supply. It takes about 2 days or 3 days for the ketone state to come in, but it has been shown again that the timing is important as well. As you can see here, the median American eating patterns, as you say, it's 8 a.m. to 8 p.m. But the early time restricted feeding means you start at 8 a.m., you finish at 2 p.m. This is the extended fasting hours for 16 hours, which is in the circadian rhythm with many of the hormonal changes taking place in the body. And I guarantee you, based on the experience, myself and so many others, if you do it, it's guaranteed to get the result for decreasing insulin resistance, improving your sugar control, In losing weight, and if you're exercising, don't look your weighing scale, look at your waist. You will see the result in the advice I'll mention. Don't worry about the weight scale. Be about your waist change, and guaranteed you will see the results. So in conclusion, a diet of 3 meals or with snacks every day is so ingrained in our culture that the abundance of food and extensive marketing has played a major role. These initial side effects usually disappear when you start the intermittent fasting with hunger, irritation, reduced ability to concentrate. Most of our patients, like you and me, are not trained how to educate our patients. Go slow, but be persistent. So the method is advise the patient to gradually, over a period of several months, reduce the time window. They can reduce by 1 hour every week or so, and they consume day on each food. Or alternatively, you can go to the 5-2 intermittent fasting diet, in which 5 days you eat normally, 2 days you are not starving. You are taking 900 to 1,000 calories per day. You start with 1 time per week for a month, then go to 2 times per week, and you are set for the next stage. And give me your results so that I can publish it. Thank you very much.
Thank you, Dr. Abdul Jabbar. That was a very interesting session. We did not realize it has so much health benefit. We all associated it with weight loss, and this is our main, where all our patients keep asking. So I'm going to go to the next speaker for the day. So this is Dr. Praveen Kumar Gupta. He is a consultant diabetologist. He's from Delhi, India. And he's going to talk about metabolic syndrome and fatty liver disease. So very closely associated with diabetes and all sorts of chronic disorders. Let's see what his experience is coming from India. And to Dr. Praveen Kumar.
Thank you, sir, for kind introduction. Thank you, Mr. Sir, for inviting me. Today's topic is metabolic syndrome and fatty liver disease, Asian conundrum. This is a best picture to describe metabolic syndrome. A statue of too much liberty. This picture shows everything. Central obesity, insulin resistance, hypertension, high LDL, low SDL. Metabolic associated fatty liver disease, formerly known as non-alcoholic fatty liver disease, is a new definition of liver disease associated with non-metabolic dysfunction and is the most common chronic liver disease worldwide. This MFLD term comes in 2020, and you can differentiate in MFLD into 3 parts: mild, moderate, and severe. MFLD affects 24% of adult population worldwide, closely related to the obesity and multiple metabolic disorder, and can vary from hepatic steatosis to steatohepatitis, then fibrosis, then cirrhosis. Previously, diagnosis was MFLD was exclusion. There is no underlying autoimmune disease, there are no underlying excessive alcohol. But now it is positive criteria. If you have hepatic steatosis, so we can say you have MFLD. High prevalence in general population make it common to coexist with other liver disease. MFLD is the hepatic manifestation of metabolic syndrome, commonly associated with insulin resistance, diabetes, hypertension, central obesity, high TG, and low HDL. Numerous factors that are investigated. IR was the stronger predictor of MFLD than CRP. That's why we can say insulin resistant syndrome, or we can say X syndrome also. Histologically, MFLD is a very broad definitely condition with a spectrum extending from non-alcoholic isolated steatosis or fatty liver to NASH. Steatohepatitis has been found in 63% of patients with steatotic liver disease undergoing liver biopsy in an Asian multi-center cohort. This is a prevalence of MFLD. In India, we can say MFLD around 30%, but maximum number of MFLD in Indonesia, it's around 52%, and lowest number in Japan, it's around 22%. The disease burden, the Asian story, almost 20% of world population reside in South Asia, making it the most and densely populated geographic region in the world. South Asians are at higher risk for obesity-related morbidity and mortality compared to other ethnic group region because high visceral body fat, thin obese, and low muscle mass and abdominal obesity. Compared to West, in South Asian country, many cases suffer from acute viral hepatitis A and C and CVH B and C. If it's not controlled, they will end up in acute or CLF, chronic liver failure. In Asia, MFLD prevalence is projected to increase by 20 to 35% over next 10 years. And recent meta-analysis said non-obese MFLD was up to 40.75%, means central obesity and same time lean obesity is also a major cause for MFLD. Amongst non-obese MFLD patients, the presence of metabolic syndrome was associated with advanced liver disease. This is a difference between MFLD and MSLD. MSLD is a very new term, and for MFLD, we have either for this, we have overweight or type 2 diabetes, and out of these 7 parameters, we have 2 metabolic risk abnormality: waist circumference, blood pressure, height, TG, low SDL, and pre-diabetes, HOMA-IR, and high CRP level. But MSLD, they mainly say if your BMI is more than 23, you comes in MSLD. So MSLD term is better for lean obese patients. This is a mechanism of MFLD. For this, contributory factor are genetic and epigenetic factor, environmental factor, diet, nutrition, and behavior therapy. For diet, for MFLD, fructose is a main culprit. And if intestinal microbiota is disturbed, they release some bad bacteria, lipopolysaccharide, and trimethylene. And same time, adipose tissue release FFA. They both enter to the liver and MFLD occur. And with MFLD, with insulin IR and cytokines, they activate metabolic inflammation, or we can say metoinflammation. And this metoinflammation is responsible for type 2 diabetes, cardiovascular disease, heart failure, atrial fibrillation, and neurocognitive dysfunction also, Alzheimer's disease, and vascular dementia also. This MFLD and long-term implication due to dysbacteriosis, gut permeability is increased, and this gut permeability mediator of gut microbiota enter in the liver, and morphology of liver is changed. And same time, there is some risk factor in the circulation also due to increased LDL, VLDL deposition, and same time some cytokine enter into the blood. and ultimately side effect is cardiovascular disease due to arterial stiffness, high BP, central obesity, and we all know 34% cardiovascular disease occur due to MFLD. Factor associated with MFLD, diet and lifestyle, urbanization and adoption of Western diet, devoid of green and legumes, sarcopenia, genetic factor, PNPLA3 gene is responsible for MFLD. Comorbidity, MFLD in Asian is present in more than 50% of diabetic patients and up to 10 to 20% may have advanced fibrosis. MFLD in patients with normal BMI is well recognized in Asia. Central obesity is often at play in such cases. This is a very good slide. This study done in Tokyo 2005 to 2005 to 21, they compiled the data of 3 million and they divide in MFLD, FLD, metabolic dysfunction, and non-MFLD. This data clearly show MFLD patients can increase risk of heart failure and atrial fibrillation. At a glance, MASH and metabolic associated fatty liver disease development is the result of worldwide growing epidemic of obesity and diabetes. MFLD is the most common cause of chronic liver disease worldwide, a major cause of liver-related morbidity and mortality. MFLD is an independent novel predictor for cardiovascular, around 34%, even when other components of the metabolic syndrome are taken into the account. MFLD is the most prevalent CLD affecting 20 to 40% of global population and 50% of diabetic Asian population. And due to this, micro and macrovascular complications are increasing. And same time, due to this, 10 to 20% may have advanced fibrosis. Thank you. Thank you for listening for this.
Thank you, Dr. Praveen. That was very good timing, I would say. So you have given us some time for discussion in the end. We used to always call it non-alcoholic fatty liver disease, but now it's called metabolic associated fatty liver disease. So that's a new change that has come across. And thank you for enlightening us. And we'll have some questions at the end.
Thanks,
And I'll call the next speaker for the next talk will be Dr. Chavi Mehra.
Okay.
So a quick word about Dr. Chavi. We have seen her many years online, but this year we are seeing her in person in Dubai. Welcome to Dubai. And so she is the Chief Medical Officer for SugarFit Healthcare in India. So she has a wealth of experience in all matters related to diabetes. And she's going to talk about some of the tech-driven advancements in diabetes care. So let's see what all tech we have in India, and let's see if we have those techs in Dubai, or else we should get it here as quickly as possible.
Thank you. Thank you. Hello, everyone. I'm very happy to be here and see all of you safe in Dubai. And I'm extremely grateful to SHAKEHEART and their chairman, Dr. Mittal, for giving me this opportunity to talk here today about tech advancements in diabetes. So if you look at that, after COVID, which is the new normal, lifestyle changes have accelerated, lifestyle disorders have accelerated globally. And especially in India, from the 2019 report, we have more than 1 million diabetics and more than 136 million pre-diabetics. And this is quite an underreported data, as we all know that we don't even have screening tests. We have blood pressure, obesity, we have cardiac disease, and of course, after COVID, the mental illnesses also took precedent. So digital therapeutics, they are software-based interventions, and they deliver medical treatments through apps, web platforms, wearables, and many other digital tools. But the main purpose, they help in behavioral modifications, cognitive training, education, and various therapeutic exercises and more. So when I look at the goals of digital therapeutics, you'll see they provide clinically effective and evidence-based treatments. This is really important. They extend the need and impact of clinicians, and they provide easily accessible, science-based or backed behavioral health solutions. And they cater to nearly every imaginative population, wherever it is, or whatever time zone it is. So just to introduce to you the currently existing technology for the treatment of diabetes, and the continuous glucose monitors are, of course, everybody's very aware of them. There are 3 different kinds actually, but the most popular ones are the interstitially sensor-based CGMs, and there's these flash CGMs that give you a few times in the day some flashes of your hyper or hypoglycemia. And then we also have now implantable CGM device, which can measure your sugars for more than 24 hours, because the others give you a trend over only 24 hours. Insulin delivery system, I won't spend time on it because you know very well there are insulin pumps, there are patches, there are smart pens, and they all are, they do dose tracking, and they do a Bluetooth connectivity, and their doses are monitored through algorithms and various regimens, which are AI ML learned. What I'm here to talk about are the mobile applications and the software solutions where diabetes management apps actually really help you in giving you precise nutrition, decision support tools, insulin dose calculators, personalized plans, telemedicine platforms, remote doctor consultations, and artificial pancreas now, which are also with automated insulin delivery with algorithms. Emerging technologies that you would really think about are, which are coming up, and quite interestingly, wearable sensors. We all know that we do sleep tracking and we do our various other parameters tracking through our wearable devices, but having glucose monitoring, sensitive glucose monitoring is in the pipeline and is going to be very soon with us. And there are even sweat-based glucose sensors. AI and machine learning is going to be unprecedented. Predictive analysis for glucose control, personalized treatment algorithms, and optimization of insulin dosing all will be done through them. Biotechnology with gene therapy and regenerative medicine, where beta cell replacement therapies are going to come, genetic engineering for improved insulin sensitivity, and long-term potential for diabetic cure might also be around the corner. Very interestingly, continuous ketone monitoring is also going to be a device which is very well going to come into the market for type 1 diabetics who have repeated admissions for DKA, and to predict upcoming or impending DKA on type 1s, this might be a very useful tool. So digital therapeutics in what I do in the SugarFit program of diabetes reversal. And if you look at it, we have basically the life coaches and the doctors as the human experts. We give you sensor, which is a continuous glucose monitor, and we do a complete blood work on you. And of course, the software technology embedded to utilize AI and ML to give you personalized insight. And all of this together they're all integrated deep tech solution. And if you see, what comes out is actually very individualized and personalized plans, which help in helping you develop behaviors or habits which help in reversal of diabetes. Just giving a patient comes on the app and initially is given their vitals to the face-based vitals and a technology in which basically they use the photoplethysmography, in which the light absorption through blood flow. And then there is a AI calculation of that light absorption and blood flow together, which is called the photoplethysmography. And through that, a calculation of your stress, your heart rate variation, and oxygenation levels are done initially. Then this is how a patient sees their daily food and lifestyle, how it affects their sugar levels, and does help them and their caregivers to monitor and optimize metabolic health in real time. There is, of course, video calls between the doctors and the life coaches at regular intervals throughout the year. There are audio calls, and then unlimited chat messages that the patient can send to the life coach and get help if needed. Very importantly, the CGM journey is really something that we found out that the continuous glucose monitors really does give a person who has absolutely no idea about what affects their sugar levels. By the end of, we just have one sensor during our whole journey of the patient with our program. But that 14-day it's amazing how a person learns about what is not right in their day-to-day habits and what is they might develop over time if they have the coaches the right habits, but somewhere the human behavior is greatly influenced by looking at your trends and has been extremely beneficial in more than 35,000 patients that we have now, about 39,000 that we have crossed. So here is something that the coach sees, and the coach then comes up when they look at it, and the system generates these insights to the coach of what happened to your patient in 24 hours. Here's the patient view, where the patient in real time is seeing when I had coconut water, what was my spike, versus when I had a Tetra Pak juice, what was my spike. There is a calculation that's put into the app where there's a calculation of your food score with the sugar level that it generates in you. And if you get a higher score, you've done well with the food. And if you get a lower score, it's not too good for you. This is what you get after your day and your spike or your trend on CGM from the coach, a personalized message. And we try to make it a lot of it is templatized by the system through the AI and ML learning that we put in, but a lot of it has to be a personalized reading by the coach of it and then giving it to the patient. There are many other therapeutic portals available in India today. And for example, the smartphone connected glucometers, and both for sugar levels, blood pressure, and vital health solutions. They have AI-based wellness supports, which analyze user data and preferences to provide personalized advice for nutrition, fitness, overall well-being, and advanced whole body digital twin technology, which also is working towards metabolic reversal. So, I mean, in my conclusion, I'd like to say that digital therapeutics with features like remote monitoring and personalized feedback empowers individuals to make sustainable lifestyle changes. And through evidence-based approaches and real-time data analysis, digital therapeutics enable early intervention and tailored treatment plans, improving outcomes. Integration with wearable devices and health app fosters continuous engagement and adherence, which is found to be the most important. If you are not able to engage continuously or connect well, adherence levels also falls to healthy behaviors. Overall, digital therapeutics provide a cost-effective, convenient, accessible, and scalable solutions for addressing lifestyle disorders and promoting long-term health and wellness. So let's join hands in moving towards a future where technology and not only enhances healthcare, but also promotes holistic approach to improve glycemic control. Thank you.
Thank you, Dr. Chavi. I couldn't agree with you more that CGM has really been a game changer. Makes our life so much easier to control sugars for all our patients. Thank you so much for your insights from India. So we'll keep the questions towards the end. You can join on the podium over here. And for our next speaker, I'm going to invite Dr. Amir Faur. He's a colleague of mine at Medcare Hospital. He's a consultant interventional cardiologist, very young doctor. And he's going to tell us about the use of SGLT2 inhibitors, which goes beyond the management of diabetes. We thought SGLT2 belonged in our pockets for internal medicine and endocrinology. Now it looks like somebody else has taken more of it. So let's hear from Dr. Amir about his experience. And to Dr. Amir.
Thank you for those kind words. And I would like to thank Dr. Metal and the organizing committee for inviting me to this conference. I'd also like to add, also the only cardiologist amongst the group here. So I hope you guys are nice to me today. And I'll try to be concise, short, and, Okay. And most importantly, informative, and hopefully won't bore you because we've talked about this topic a lot, particularly SGLT2 inhibitors. So I'll try to provide a concise summary. The outline of my talk will involve a bit of history of SGLT2 inhibitors. To be honest, that was the most interesting part of preparing my talk, is the single slide that will be next, which I found most interesting, the background of SGLT2 inhibitors, results of the major cardiovascular outcome trials, and some of the proposed putative cardiorenal protection mechanisms of action, and positioning of SGLT2 inhibitors amongst the most recent guidelines. Just a brief question. Anyone want to guess when was the first SGLT2 inhibitor discovered? How many years ago? How many years? 100? Yeah. Actually pretty close. So 189 years ago. It was discovered in 1835. It was called fluorosin. Fluorosin was isolated from the root bark of the apple tree. And it was used to treat malaria. I don't think it was very effective. Fluorosin was not only an SGLT2 inhibitor, it was also a non-selective inhibitor. It also blocked SGL1 in the gastrointestinal tract. And probably 4 decades later, it was realized that it causes a glucosuria, and consequent plasma glucose lowering effects were realized. But only until 1962 did they realize that it was a competitive inhibitor of the active process of sodium glucose co-transporting. And in 1996, in Japan, the first analog of fluorosin was engineered. The reason why fluorosin wasn't used is because it had poor oral bioavailability. And because it inhibited SGL1, it caused a lot of gastrointestinal side effects. So we all know SGLT2 inhibitors were primarily initially used to reduce blood sugar levels, and currently they have largely replaced as a first-line sulfonylureas and even basal insulin therapy. And just as an idea of how effective they are, they're probably equally as effective in terms of glucose lowering potential as DPP-4 inhibitors, and probably less effective than GLP-1 receptor agonists. The focus in my talk would be on the cardiorenal outcomes or beyond diabetes, use of SGLT2 inhibitors. And I think this slide says a lot. These are the 4 initial cardiovascular outcome trials that looked at SGLT2 inhibitors. The first one, I believe, was in 2015, EMPA-REG outcome that looked at empagliflozin. Canvas looked at canagliflozin. DECLARE was dapagliflozin, and VERTUS was ertugliflozin. And as you can see, all of them, without exception, reduced hospitalization and heart failure, and the composite endpoint of cardiovascular death and hospitalization of heart failure. And these are trials that were conducted in diabetic patients at high cardiovascular risk. So these are patients who had diabetes, had established atherosclerotic cardiovascular disease, or had diabetes and were greater than 50 years of age with at least 2 risk factors. Of note, the EMPA-REG outcome trial, which used empagliflozin, was the only one that reduced all-cause mortality and cardiovascular mortality in this group of patients. Next, I'm going to talk about the use of SGLT2 inhibitors in patients with chronic heart failure. So this is stable heart failure patients with or without diabetes. 4 trials across the board of left ventricular ejection fractions. Again, dapagliflozin and empagliflozin in patients with a reduced ejection fraction or patients with preserved ejection fraction. They've showed consistent results across the spectrum of left ventricular ejection fraction, with reduction in hospitalization of index heart failure and cardiovascular deaths and heart failure. As opposed to the previous slide, where empagliflozin was the only one that showed a reduction in all-cause mortality, dapagliflozin in this case was the only one that showed a reduction in all-cause mortality. So the results are homogeneous and significant for across the spectrum of LV ejection fraction. This is a meta-analysis that looked at the 3 studies that were published that looked at patients with acute heart failure. And the largest of them used sotagliflozin, which is, I don't think is commercially available, but is a SGL1 and SGL2 inhibitor. And the rest were smaller studies, but the soloist WHF, as you can see, had the highest number of patients. And it showed that there was a reduction in rehospitalization for heart failure, however, a non-significant trend towards a reduction in all-cause mortality. And there wasn't any signal for any safety events. So even in acute heart failure, the soloist trial, this meta-analysis showed an improvement in rehospitalization for heart failure. In patients with chronic kidney disease, this is a meta-analysis that looked at the initial 3 cardiovascular outcome trials of SGL2 inhibitors, and also the dedicated trial Credence that looked with canagliflozin that came out later. And you can see across the board in hard endpoints, hard renal endpoints, it showed significant improvement in the composite endpoint of dialysis, transplantation, or death due to kidney disease, the development of end-stage kidney disease, substantial loss of kidney function, end-stage kidney disease or death due to kidney disease, or death due to cardiovascular disease, and even in acute kidney injury. So this is where things started to change and started to show that even in patients without diabetes, if you have chronic kidney disease, you'll benefit from having an SGL2 inhibitor. And this is a slide showing the specific dedicated trials that looked at patients with chronic kidney disease. Credence, DAPA-CKD, and empagliflozin, canagliflozin, dapagliflozin, and empagliflozin. Very consistent, homogeneous results. The primary outcome is an outcome of hard renal endpoints and cardiovascular death. The renal outcome is hard renal endpoints without cardiovascular death, and even end-stage development end-stage kidney disease, they all were significant. This is something I also found interesting as well, and it's talked about a lot. The GFR dip. SGL2 inhibitors induce an acute reversible reduction in GFR. And interestingly, the larger the magnitude of the dip initially, the more it's associated with a more positive intrarenal hemodynamic effect rather than a deleterious effect. So if you have a patient that has a significant drop in eGFR that's normalizes, usually by 12 weeks, this is the patient that is reaping most of the benefits compared to a patient who is a non-dipper or does not have a change in eGFR. This is a slide to show you the wide range of proposed cardiorenal mechanisms, and really most of them haven't been proven yet. And every several months, an article comes out that disproves or proves one or the other. For example, if you look at the one under kidney where it says increased natriuresis or diuresis, a paper last week, which I did not include a slide for, apologies, but it showed that there's increased natriuresis in the first 24 hours. However, after 24 hours, there's a compensatory increase in ADH.
Milk here? Oh no, it's full.
Other interesting mechanisms include increased erythropoietin production and improved energy metabolism. There's also decreased inflammation by suppressing the NLRP3 inflammasome. And this is a slide that is based on a study in diabetic rats with cardiomyopathy. And essentially what was shown is that there's increased ATP production in the hearts of rats that took SGLT2 inhibitors, primarily due to an increase in glucose oxidation, ketone oxidation, and glycolysis. So the coupling between glucose oxidation, ketone oxidation, and glycolysis changes in the hearts of patients with SGLT2 inhibitors. That's thought to be because your SGLT2 inhibitors increase serum ketones, even in the absence of hyperglycemia. And because ketones are increased, the heart is able to utilize ketone oxidation more. So I'll finish off with the guidelines, and I'll be quick here because this is relatively easy compared to the flowcharts that endocrinologists have. This is one box. If you have a patient with heart failure with reduced ejection fraction, SGLT2 inhibitors are class 1. In mildly reduced ejection fraction, also class 1. And patients with the preserved ejection fraction, also class 1. So it's very easy to remember. And even in patients with chronic kidney disease, also class 1 indication. So that's very easy for us cardiologists. You can use it on pretty much almost everyone. And finally, I'm going to finish off with the slide. SGLT2 inhibitors can be used in patients with diabetes, with or without high risk features, in patients with heart failure across all the spectrum, and in patients with chronic kidney disease. And I'll just finish off with a recent study called Impact-MI, which was published last week, which was a negative trial that looked at SGLT2 inhibitors post-MI, which is consistent with the DAPA-MI published last week. So whether or not we will see another box there in the future remains to be known. Thank you very much.
Thank you, Dr. Amir. Yeah, I think we'll open for another 5 minutes for some questions from the audience side. I will just ask the first question to Dr. Abdul Jabbar. Regarding intermittent fasting, how would you advise it in case a diabetic patient wants to go on an intermittent fasting? How would you advise that patient?
As we said, intermittent fasting is not a diet plan, it's an eating pattern. So whatever they are eating, as their diabetes diet, they can continue with that. It's just the time-restricted eating, they're eating. But as you rightly pointed out, many of the diabetes patients are taking medications related to their food intake and meal intake, especially if they are insulin. So it's better to get in touch with their doctor to modify the timing and the dosing of their diabetes medications to reduce the risk of hypoglycemia.
Yeah, sorry, I will just interrupt. Yes. Yeah. I was going to ask this question, but already I can tell you one thing. One single study not very well done, and probably it was done by a fellow somewhere in a department, and he published it. This is what I feel. What is your take on this?
So very much, this is the hot topic about intermittent fasting. This was not a study. That was an observational recollection of the data collected for other purposes. And they just asked the patients for the last 29 years, what was your time of eating? And you know, if I start today, oh, I was eating this time and I was not eating this time. So there are many counter arguments or the expert opinions very well published. I didn't have time to discuss with that, which has said, in no way it suggests that it is more hazardous and there is no harm for the people who are already doing intermittent fasting, and the expert opinion coming from the experts in the field, please don't stop your intermittent fasting.
Yeah, I fully agree that a study has plenty of pitfalls. It was an observational data, retrospective, lot of confounding factors. So that should not be taken as a changing the clinical practice. I have to just add 2 points about the SGLT2 inhibitors. All the various aspects have been highlighted. Now the SGLT2 inhibitors have got a class 1A indication even in patients of heart failure with improved ejection fraction. That's another phenotype which has not been included in ESC guidelines but has been included in ACC/AHA guidelines. The second SGLT2 inhibitors decreases the uric acid significantly. And a lot of trials are going on in that direction. Can SGLT2 inhibitors can be used as an agent decreasing uric acid? The only advice which I give to my patients, whenever you prescribe, always advise patient to maintain a good urogenital hygiene. That's the one. Two, if your patient is undergoing surgery or an acute crisis, SGLT2 inhibitors should be stopped 3 days before. Thank you.
I think I will ask just one more question to Dr. Praveen Kumar Gupta.
Yes.
So there is a lot of medications available for treatment of metabolic liver disease. If I was to pick one medicine, which one would you suggest?
Pioglitazone only, insulin sensitizer and vitamin E. 2 medication you can give, but this medicine, diet and exercise and control your diabetes, control your hypertension. But insulin sensitizer, pioglitazone is best drug for MFLD patients.
How about GLP-1, either semaglutide or tirzepatide? Any data on
We don't
these?
have any robust data to tell this is GLP-1 is working or not working. If I will give, I will go with GLP with SGLT2 inhibitor.
So as the studies are going on for SGLT2 and GLP-1,
Yes, sir.
they've shown in the data that it decreases the liver fat, but the long-term outcomes are still not known. And number two, at what stage of liver disease? So it is not part of any guidelines yet, but obviously by default, 70 to 80% of these patients are obese and diabetes. So you are receiving already these medications. You don't have to give it for fatty liver disease.
That's
And
why
then
they are
they
giving with
increase their-
GLP with SGLT2 inhibitor both.
And they increase their weight again if you give pioglitazone. So that's another issue which we very often see in our patients. And many of our patients in our practice are also having some kind of heart failure. So again, this is a contraindication. But this is a PPAR, as you say, PPAR medication. So it is like fenofibrate in a way. They both work kind of similar way. So they tend to increase the HDL also, which is not well described by the company anyway for pioglitazone, but yes, it is. You may agree with me that it also increases the HDL to some extent. So I have the last question from Dr. Shavi. So you said you have 39,000 patients by now within your organization. So what is the cost per person and what is the actual execution of the program on a given patient? Suppose I bring one patient to you. How will you execute this whole digital thing or what will happen? How the process will go? Very quickly, if you can summarize.
So the patient, I have the speaker, yeah. So the patient registers online and once they register and they get onto the program, it's a 12-month program. And in the 12-month program, the patient is assigned a life coach, which is actually very culturally matched. For example, if you were from East India, you get a coach from East India. If you were from the Western belt, Hindi-speaking belt, you would have Northern and Western belt, you would have that. So the cultural matching is extremely important in India, with, as you know, with the different languages and different geographical, culturally diverse that we as a country are. So they have tried to match, about 90% of them are able to match. We have a big percentage of coaches, and then
doctor is assigned to them. A coach sees them, they're onboarded and they're given 3 one-hour lectures or video consultations by the coach to explain to them exactly getting their history, trying to get a connect, trying to understand their cravings, whatever that is, their past medical histories, just getting to know them very well, devising in the second welcome call extensive plan dependent on what they got in the history in the first, and then the third welcome plan is mainly to devise a personalized physical fitness approach to you as you are. You could be somebody who's had both knee replacements, you could have anything that is going on with you, depending on that, giving you a very gradually progressive fitness plans. We also have live trainers on our apps. We have on the app itself, we have about 800 training sessions in 20 minutes each, designed for strength and conditioning, for TheraBand exercises, for how to go on to weight training, as it has clearly shown that moderate strength and conditioning is one of the best form of exercises, rather than walking alone, which is prevalent, which is good, always good, but getting into strength and conditioning and building up muscle. We also have these 3 things are set up by the coach in the first 3, and then the doctor sees them with the complete blood work that we send somebody to their home to collect. And so complete blood work means every single thing, LFT, KFT, everything, and their past history is collected, their personal, psychosocial, and we also have them fill a DDS form, which is diabetes distress assessment. So we do believe that behavioral modifications cannot be done until and unless you understand the emotional capability, or they're going through. A lot of diabetes patients have depression and have an issue with stress and just very frustrated with managing over the years their diabetes, getting all kinds of inputs. So basically totally, and we have an entire association with us online psychologically assessment and trained psychologists who work with our patients if we find them into moderate or severe DDS. We also have psychiatrists on our platform. So it is basically the doctors will look at the patient, the CGM is put on them, and slowly over the year, there are these small habits of behavioral modifications with the help of an extremely empathetic and supportive coach, which is generated. Insights are given, the patient is all very involved. Our main thing is how involved and how many touch points we assess every week has a patient done on the app, and how much utilization of our services, mindfulness videos, sleep helps, we have yoga nidra sessions, we have yoga classes, we have every single thing.
Great.
And it is just amazing. The results are mind-boggling, but quality controls and making sure that it is not just the tangible, physical or medical aspects, but also understanding the intangibles, which are actually a lot of mental.
So I think we will hear more about this a year later, so you will have more data and you can present much better, but congratulations for your program.
We do
and
have significant data, and we have published and we've done peer review journals. We have been invited all across the board, ADA, ATTDs for our,
Thank you so much, and Dr. Jabbar will conclude the session. And
we had a very good session again. From morning, you were talking about intervention and cardiology and everything, where we are going to how to prevent our patients from going to cardiology. So that's what we are working, and I think pretty successful in the session as the questions and answers are saying. Thank you very much for attending.
Thank you so much. Thank you, everybody. So moving on, the next session is from Cardiological Society of India, UAE chapter. This chapter was founded about 13 years back with me and some of the colleagues, which is thriving, growing very well. We have a number of people here and we do annual meetings. And this year we had a collaboration with CSI UAE chapter. And this one session is entirely dedicated to CSI UAE chapter, and the theme is the guidelines. The session director is Dr. Rajiv Gupta, who will come, and Dr. Rajiv Gupta Yes, please come over and take the dais, and you have 60 minutes from now. And we are almost on time, but we want to maintain this 5-minute deficit which is going on, but I think we can do it. Thank you.
So, good afternoon. You had a cup of tea? I think you should pick up if you haven't done so far. So, we start session, I mean, the 5-7 minutes little late, but I think this is also adds to your knowledge that what the guidelines says, because clinical trials is a one set of the learning, the guidelines are another thing. All the clinical trials are critically analyzed, assessed by the best minds in the field of medicine, horses, and then they lay out the guidelines, which are very prestigious. So we shall share the guidelines. Along with me, I have got my co-chairs who please join me wherever you are sitting. Down with me is Dr. Yes. So kindly join me, all the people, those who are there in the list, and I shall appreciate so that we generate a good discussion basically. So Murli is there, Rupesh is there, and Dr. Praful Mishra are there. So kindly join me over the dais, and we have good speakers to share with us the highlights from the guidelines. I know guidelines are very lengthy affairs. When you read them, 75 pages, 100 them, it's not possible to read them, but they will try to summarize in a sense, and we have been requesting them to keep it to the interested points so that we can take up these interesting points to generate a interactive discussion. So one of our first speaker is Dr. Amrish Agrawal, and he doesn't need any introduction to the gathering. He comes from a senior consultant cardiologist from the Fujairah Hospital, Fujairah, and he's a prominent speaker involved with most of the conferences regionally and internationally, and he speaks on the Heart Failure European Society of Cardiology 2023 guidelines.
Thank you very much, Dr. Gupta. This is and failing heart. Don't think this is a left ventricular assist device. So today I've been asked to speak on what is new in 2023 guidelines, which is very good because this is not a guideline. This is an update of the guideline. And we have only 12 minutes. So obviously you cannot present the heart failure guideline in 12 minutes, but an update is possible to concise and to squeeze in 12 minutes time. So what the guidelines do is that this particular update included the trials which were published after the previous guideline until 31st March 2023. They included only those trials which may change the guidelines in class 1 and class 2 recommendation. That means anything which they thought is class 2B or class 3, they did not include only class 1 and class 2A recommendations. The organizers or what we can say the writers, they considered many trials which were coming in this time. And the top one, which I put in the yellow box, the one which we'll discuss in the detail, but other trials also relevant. For example, the REVIVE trials and the TMR trials for the mitral clips, they said we want to include in this update because there are separate guidelines coming which are focusing on these trials, and those guidelines are related with the result of this trial. And secondly, there were certain trials which are important, which are relevant, and I included them, which are Edward, Chlorotecan, and GLIDE IT heart failure trial. So what are the trials focused on? The trials, first trial set of trials which are focused on the role of SGLT inhibitors, which is already highlighted by my colleague Dr. Amar before, but I will just show in 2 slides that particularly for the first time, the heart failure with a mid-range ejection fraction have 2 drugs which are class 1. First is diuretic, and the second one is SGLT inhibitors, so dapagliflozin, empagliflozin, and mentioned by names as a class 1 recommendation. This is for the population with the mildly reduced ejection fraction. Second is the population with the preserved EF, and all of us know because we have been honed and we have been talking by the industries over a number of trials is that only SGLT inhibitors remain as a class 1 indication in this class, and this is because of the 2 trials which were emperor preserved and the delivered trials. So that means when we talk about preserved EF, only one class of drug has a class 1 recommendation. When we class of mildly reduced EF, some class of class 1, but there are some drugs with a class 2A recommendation and 2B recommendations. Now we come to the second set of trials. There are second set of trials which can be divided into 2 categories. The first categories are focused on the acute decompensated cardiac failures, Among them, 3 trials are considered, which are diuretic trials, and one trial talk about the strategy, and the second set of trials are the trials which talked about comorbidities in the heart failure, which is mainly, we all know what are the comorbidities we are concerned with. We are concerned with diabetes and the CKD, and particularly the emphasis on the iron trials in this population. So what about the treatment in the acute decompensated heart failure, which is the first set I would like to consider. So the acute decompensated heart failure, we all know if the patient comes with decompensation, what do? We give them diuretics. But we all know, and there is no trial to show that diuretics have an impact regarding mortality and morbidity. But obviously, this is not the target of a physician. The physician target is also the patient to feel better if the treatment is not doing any harm. For this, diuretics excel. They improve the patient's shortness of breath very rapidly. And we also know that if the acute diuresis is not working, the only thing which we do is increase the dose of Lasix. So somebody goes on a loop diuretic for 40 milligram BID, then escalating intermittent infusion, we are going. So the guidelines examined what 3 trials looked in this point. Can we do some additive therapy to make that loop diuretics work a little better? So as I show you, there were 3 trials which were done. The first trial was done with regard to hydrochlorothiazide. It was called Edward trial. The second trial was regarding the diuretics of hydrochlorothiazide, which was called a chloritic. And the third trial was with empagliflozin, which is HGOT inhibitors. We have been told by many speakers that don't start empagliflozin in the population which is decompensated, but they looked in the patient with the decompensated heart failure, what with the impact. On the right-hand side, you can see the maximum impact regarding the increase of the urine occurred when you give this SGLT inhibitors in combination with the loop diuretic. This was followed by the dose of hydrochlorothiazide in the dose of 12.5 to 50 milligram, depending on the GFR, and the least response was seen by the acetazolamide. So it appears that when you give them additive therapies along with loop diuretics, you can make a meaningful difference in the degree of decongestion. So this is one strategy. The second strategy, which will look by the trial, which were the guidelines, because this was a very strong and different than the conventional trial, was how do we improve the outcomes for the patient with heart failure. So we have a sequence when the patient with decompensated cardiac failure, he goes to emergency department, he admits the intensive care, then goes to the ward and comes to the clinic. So the researchers, they look at one particular point, which is the transition from the inpatient to the outpatient, which is the peri-discharge period. So they look, can we implement some strategies in the peri-discharge period? And this trial was called a strong heart failure trial, which looked at the new upward titration strategy in this population. What do you mean by that? This means what that the researchers took 2 groups. In half of the groups of these patients, from nearly 1,000 patients, what they did the standard therapy, let the discretion of the physician. But in the second group, unless there is a contraindications, the patient left the hospital with at least half of the guideline-derived medical treatment doses. Because we know there are 4 molecules we have to use, but all of us, if you use, they use them maybe 10-20% of the doses. So they try to use 50% of the doses, and they followed this patient after 1 week of discharge, 3 weeks of discharge, and 6 weeks of discharge. And they really found that the population which become more intensive treatment, there was a rapid upgradation or upscalation of therapies. And what is the extent that we can see that the full doses, 55% of patients could achieve this full doses for the ACE inhibitor RNA, which is the most difficult class, and 50% could achieve for the beta blockers, and nearly 85% could achieve by the MRA. Did it make difference in the outcome? The answer came, they really made a difference in the outcome. You can see there was nearly 8% absolute difference between the high intensity care versus moderate intensity care. And the difference was related to the difference in the heart failure hospitalization. There was no difference in the mortality, but what was improvement was the improvement in the visual acuity score regarding patient feeling of better. So it appears that rapid titration of medical therapy is feasible. Not only is feasible, it is doable in majority of cases. And the emphasis, physicians should be doing it. And what the guidelines did? They said, I want you to read it very carefully. Our intensive strategy of rapid titration is now a class 1 recommendation with a rapidly and frequent follow-up, not after 6 weeks, not after 1 month, after 1 week and 3 weeks. So more rapid, more clinical appointment after the clinic. And after this trial is published, we typically see the patient in our heart failure clinic at 2 weeks from discharge. So this has now become a class 1B indication in the guideline for the heart failure. Subsequently, the guidelines also focus on 3 special strategies, which are the two comorbid conditions, which is diabetes mellitus and CKD. So what is new regarding this condition? We know that the SGLT inhibitors are very, very helpful, and Dr. Amar showed us different data regarding mortality reduction, morbidity reduction. But the 2 more common conditions we deal in cardiology is diabetes mellitus and CKD. And there was a meta-analysis which was published which looked at nearly 13 trials and 90,000 patients. And the meta-analysis looked at the differential effect of SGLT inhibitors when diabetes mellitus occurs with CKD. What did they find? They found that if you have a background of heart failure and CKD, it does not matter you have diabetes or not diabetes. There's impact and benefit of SGLT inhibitors. But if you have only CKD, then there's a differential effect. Only the population with diabetes mellitus, they have a benefit of SGLT inhibitors, and only the patient with CKD alone with the diabetes will not have any benefit regarding heart failure outcome. Second set of trials which looked at the non-synthetic, we can say non-steroidal melanocorticoid receptor antagonist, finerenone, which is the flavor of 2024. And there were two trials which were done, which are called a Fedalo trial and the Figaro trial. I will not bore you with the details. This is for the nephrologist. But what we are concerned as a cardiologist is the pooled analysis. And this pooled analysis is called the Fidelity trial. And the trial showed reduction in the composite endpoint, including the 3 TP endpoints and the heart failure hospitalization in the patient with finerenone placebo. And the guidelines now say that the class 1 indication for patient with diabetes mellitus and the patient with the CKD, the use of SGLT inhibitors and use of finerenone. So if you have diabetes and CKD, please, these two drugs are now class 1 indication. And this is first time European Society of Cardiology guidelines are not talking about treatment. These drugs are to be used in this population to prevent the development of heart failure. So we have gone actually down the line in preventing the heart failure hospitalization. The last part of my talk is focused on the second part, which is a comorbid condition with the heart failure, which is iron deficiency. What is new about iron deficient heart failure? I mean, we know that we have been using iron deficiency in the population with the heart failure. The guidelines looked at a particular point. In 2021 guidelines, the guidelines talked about two indications, which are given class 2 indications. The two indications are ferric carboxymaltose. That means only one drug which is recommended, which is ferric carboxymaltose, to improve heart failure symptoms, exercise capacity, and quality of life. And also class 2A to reduce heart failure hospitalization. But subsequently, since these guidelines were released, there was a new set of trials for an Ironman trial, which came with another molecule, which is called as the ferric deoxymaltose molecule. And secondly, a meta-analysis, a very strong meta-analysis, a big meta-analysis, which included nearly 10 trials. And now the guidelines have become much more simple, less complicated to remember. What do the guidelines say? They've said that intravenous iron supplementation is recommended to alleviate heart failure symptoms and the quality of life as class 1 indication. No more class 2A, it has become now class 1 indication. And they said that you can use any of the iron infusion which are recommended. You can use carboxymaltose or you can deoxymaltose in the population to reduce the risk of heart failure hospitalization. And this is class 2A recommendation. Now, coming back to the heart failure, we come back now to say the summarize, because Dr. Gupta gave me the task, leave a couple of minutes for discussion and then to answer the questions that what do the change occur in 2023 as compared to 2021. The changes is first the solidification and the concretization of SGLT inhibitors in the population with the reduced EF, mid-range EF, and the preserved EF, and for prevention of development heart failure in the population with diabetes mellitus and CKD by SGLT inhibitors and by finerenone. This is the important change which occurred. Second thing is that very, very importance of uptitration therapy strategies, that you rapidly uptitrate inside the hospital, pre-discharge, and the first few weeks of discharge. And there is a new evidence of iron supplementation for the heart failure patients with iron deficiency. You have to show iron deficiency, and I'm sure everybody knows it is not at all dependent on hemoglobin. It's dependent upon iron levels. It is dependent upon the TSAT levels and dependent on the ferritin. And new diuretic regimens for the population with acute decompensated heart failure. So with this, I come to the end of the talk.
Great, you finished in time, excellent. So that's fine. So I like to take that you have really done a good job to summarize what was we were having the thoughts, and now the thoughts are on the horizon, and what has been proven and you have talked. And so I like to take up the issue, let us say Dr. Praful Mishra or Rupesh or Dr. Murali, anybody can address how do you see the use of the SGLT2 inhibitors in patients with heart failure without diabetes, let us say. What you feel, what is your take on from the guidelines, what you feel?
Almost 100% of our patients are now on SGLT2 inhibitors if they have heart failure.
Regardless of the diabetes.
Regardless of diabetes.
So that's very clear, regardless of the diabetes. Could you enlighten us, Dr. Amrish, about, let us say, patient who doesn't have diabetes but CKD? How do you feel about SGLT2 inhibitor?
So I will say once again, re-emphasizing what Dr. Professor said, all categories of heart failure, as long as the GFR is not the 20, that is of SGLT inhibitors. These we are talking about symptomatic heart failure, symptomatic. Now, if you have somebody who has got diabetes mellitus and a CKD, SGLT inhibitors are again class 1 indication for development heart failure. But if you have CKD alone, then they will not prevent heart failure development. They can prevent deterioration of renal function. That's a different component. That is for the nephrologist. But from the cardiology point of view, there is no indication in the cardiology guidelines for prevention of heart failure.
Fine, good. So basically, when you want to retard the renal dysfunction, you will continue to use regardless of diabetes, SGLT2 inhibitor, because that's also one of the targets. And but regarding heart failure, you may not get benefit in non-diabetics, but in diabetics, of course. So therefore, CKD, regardless of diabetes, remains an indication, because tomorrow the worsening of the renal failure will lead to indirectly worsening of the heart failure also. So, but he's right that CKD without diabetes, it will not prevent, but you can use it for the welfare of the CKD. So that's the point, which sometimes some people may confuse it. So fine, so that's good. Regarding iron deficiency, he has emphasized upon regardless of the hemoglobin level. So basically you look for the tissue iron deficiencies and then you treat tissue iron deficiency. Oral doesn't work, it's what work is only IV. But along with IV, there is no role of erythropoietin. We don't use erythropoietin, isn't it? Because even in the renal impairment, there is no need to use erythropoietin, the IV iron works. So that's fine. Can we go to the second talk about the updates on the atrial fibrillation, and Dr. Sandeep Golcha talks about it.
Good evening, everyone, and thanks to sir to give me an opportunity to talk about recent guidelines. And as told by sir that I have to keep it short so there can be more time for the discussion. But it's really difficult to summarize the guidelines within a duration of 5-10 minutes. I will try my level best, and maybe I might skip some things because of the time constraint. So we will try to make up that in the question answer. So in the 2023 guidelines, there have been certain changes in the definitions and the recommendations for the catheter ablations, rhythm control. I will be discussing more about the stages of the atrial fibrillation because this is a new change from the latest guidelines, and then subclinical AF, and some slightly I will be discussing regarding the treatment patterns. So in the new guidelines of atrial fibrillation, now they have given is a pattern of like classification of heart failure. Like in heart failure, we classify as at risk, pre-heart failure, and then heart failure, and then treatment. So same thing they have classified for the atrial fibrillation also. It's like patients who are at risk of atrial fibrillation, pre-atrial fibrillation, and then the actual atrial fibrillation, which contains the paroxysmal AF, persistent AF, long-standing persistent AF, and treated AF. And the final category is the permanent atrial fibrillation, when we just give up the hope of controlling the rhythm. And in the definitions, few terminologies they discourage to use and they consider it's obsolete, like chronic AF, lone or valvular AF. These terminologies should not be used currently. And one newer thing which they have classified is subclinical AF. When patient doesn't have any symptoms of atrial fibrillation or doesn't present as atrial fibrillation, but probably the other devices which have been implanted for the different purposes, which pick up the atrial high rate episodes or palpitations. So this has been considered as a risk factor, and it is defined as a subclinical AF, and there has been different recommendations for the anticoagulation for stroke prevention in these patients of subclinical atrial fibrillation. And now in these guidelines, they emphasize more towards the lifestyle and risk factor modification for the treatment of atrial fibrillation, other than that the pharmacological method for the actual prevention of stroke in patients. Other than that, risk factor modification is given more emphasis to consider in each and every patient. And there are some certain risk scores which should be considered in each and every patient, which predispose them to develop atrial fibrillation. like patients who are coronary artery disease, chronic obstructive pulmonary disease, diabetics, hypertension, systolic heart failure, and thyroid disease. If we score the patient according to this criteria, this is chest score. The more scoring predisposes the patient or gives the more chances of the patient can develop atrial fibrillation in future course. And this is the most important slide in these guidelines, which summarizes the treatment modalities for the atrial fibrillation. I will be discussing this in the end also. So I will. What they said is, whenever you detect a patient of atrial fibrillation, the emphasis should be for the prevention of the stroke, to address the risk factors and try to modify the risk factors, and then the symptom burden of atrial fibrillation should be managed by the rhythm control or the rate control. Other than that, risk factors should be changed, like heart failure, exercise, arterial hypertension, diabetes, tobacco, that is smoking cessation, obesity, ethanol consumption should be reduced or curtailed, and proper sleep should also be promoted in these patients to prevent the further occurrence of atrial fibrillation or to maintain the sinus rhythm. Now, whenever we come across to a patient of atrial fibrillation in the clinic, the first and foremost goal is to prevent the stroke risk. And to prevent the stroke risk, there are certain risk factors which should be considered. Certain risk scores are there. Now, CHAD-SWAS score is most used in the clinical system. There are other scores also, but the clinical practice is mainly based on the CHAD-SWAS score only because it's easier to use, and now it's more in the contemporary practice. So whenever there is a patient of atrial fibrillation, his CHAD-SWAS score should be classified, and depending on that, he should be a candidate for anticoagulation as per the CHAD-SWAS score. Other scores are also there. Initially, we used to use CHAD score, but then later on it was modified to CHAD-SWAS score because that was more practical and that classified the more risk behaviors. But still, there are some certain risk factors which are not addressed, like there is an atria risk score which includes more renal patients, because CHAD-SWAS score doesn't give consideration to the renal risk factor for the stroke. And certain trial has shown that the kidney diseases are considered probably an independent risk factor for the stroke in a patient of atrial fibrillation. And other one is the Garfield score, but it is a web-based score and it's little complex. So I think in clinical practice, it's difficult to use in day-to-day practice. Other than the classical risk factors, there are certain risk modifiers or some additional risk factors which predisposes the patient for the stroke risk other than the CHAD-SWAS score. These are the higher AF burden, persistent or permanent AF, obesity. Hypertrophic cardiomyopathy is considered a high risk for the stroke, irrespective of the CHAD-SWAS scoring of the patient. So any patient who has a atrial fibrillation with the background diagnosis of hypertrophic cardiomyopathy becomes a candidate for anticoagulation, irrespective of his CHAD-SWAS score. So we all know about the CHAD-SWAS score. This is the acronyms which define. And whenever we are talking about the CHAD-SWAS score, we need to define the stroke risk of the patient. So a CHAD-SWAS score of 2 or more gives a greater than 2% annual risk of the stroke, which is considered high risk. CHAD-SWAS score 0 in the man or 1 in the female gives a stroke risk of less than 1%, which is considered low risk. And between 1 to 2 is the intermediate risk for the stroke. That will be the CHAD-SWAS score of 1 in the man or 2 in the female. Back is full. So whenever we are considering the anticoagulation, any patients who have a high risk score, that is annual risk of more than 2%, or CHAD-SWAS score of 2 in men and 3 in female should be considered for the anticoagulation. And intermediate risk score candidates also should be considered for the anticoagulation. Low risk patient doesn't need anticoagulation. And whenever we are talking about the anticoagulation, there are vitamin K antagonists and these direct oral anticoagulant agents are there. So in patients who are not moderate to severe mitral stenosis or who doesn't have a mechanical prosthetic valve, other than these patients, DOAC should be preferred over the vitamin K antagonist. In mechanical prosthetic heart valves and moderate to severe mitral stenosis, vitamin K antagonist is preferred over. DOACs are not used, only vitamin K antagonists are used in these patients. And these are the DOACs because now DOAX has multiple pharmacokinetic and pharmacodynamic profiles, and depending on the creatinine clearance and renal parameters, the dosage adjustment should be there. Only thing is that apixaban is the agent which can be used with GFR of as low as 15, because for the apixaban dose adjustment, we need to consider 3 criteria like age more than 80, body weight less than 60, and creatinine more than 1.5. If 2 out of 3 are present, then dose should be reduced to half, 2.5 milligram twice a day. Other than that, it can be used 5 milligram twice a day across all GFR categories. And there nowadays they recommend that rivaroxaban also can be used at a reduced dose of 15 milligram once a day for these patients or having low GFR, 15 to 30 or less than that. But I think clinical experience is more with the apixaban in these kind of patient. And in trials also, rivaroxaban has been shown to have little more bleeding risk than compared to apixaban. Device detected AF, which we define as a subclinical AF. So there has been recommendation for this. And this is an important aspect which should be taken into consideration whenever a patient who has an implantable device, and when programming or interrogation tells us about a high rate episodes, then that should be first visually confirmed by the clinician to document it as a subclinical AF. And then patient should be classified at the chest score. And depending on the duration of these episodes, if AHRE is more than 24 hours, then a chest score of 2 or more gives guideline for the starting of anticoagulation. And if AHRE is between 5 minutes to 24 hours, then chest score of 3 or more should be there to start anticoagulation. Any AHRE less than 5 minutes is not considered as atrial fibrillation, so they are not a candidate for the anticoagulation. And other than that, lifestyle and risk factor modification has been given more emphasis. Treating the obesity, physical inactivity, curtailing the alcohol consumption, smoking cessation, and treating the diabetes and hypertension also has been given the problem. Then other than the pharmacological treatment for the stroke risk prevention, that left atrial appendage occlusion devices has been approved as per the PREVAIL and PROTECT AF trial. So left atrial appendage occlusion devices has been given the class 2A recommendation for the treatment of stroke prevention if there is a contraindication for the anticoagulation, or if the long-term anticoagulation warrants high bleeding risk in the patient. And bleeding risk should always be, whenever we are treating any patient with atrial fibrillation for anticoagulation, the bleeding risk should be calculated, and current scores which are used are like Hess blood score and hemorrhage score. And if any patient having a considered high bleeding risk for the anticoagulation is also can be considered as a candidate for left atrial appendage occlusion devices. Whenever we encounter any bleeding with the anticoagulation, then with the warfarin, we all know that prothrombin complex concentrate or vitamin K is the antagonist or treating agent for the warfarin-induced bleeding. And with dabigatran, etarucizumab is an agent, but I don't think how many people are using dabigatran nowadays. It's not commonly used clinically. And with the apixaban, rivaroxaban, adnaxad alpha is a agent which neutralizes the bleeding side effects if there is a significant bleeding. And for adoxaban, it's not recommended, but it can be used as an off-label agent. And whenever we encounter patients of atrial fibrillation who are on anticoagulation, but they need some different types of surgeries also or some other procedures, then stopping the anticoagulation is also comes across very commonly in the clinical practice. So if any patient who is on anticoagulation but is not a very high risk for the thromboembolism, like a risk scores of more than 3 or mechanical heart valve or previous stroke, then there is no need to start a bridging therapy. Just interruption of the anticoagulation and going ahead with the surgery or any procedure is good enough. And if a certain kind of patient is going for the pacemaker or something, then same thing can be used. And if the patient is high risk, then rather than going for the bridging therapy, the warfarin can be continued for the pacemaker. That was the Bruce control trial which commented on this. And whenever it comes to the symptom control, rhythm control should be given more emphasis. The trials actually shown that whether we go for the rhythm control or rate control, the outcomes for the in the terms of mortalities are not different, but we all know that quality of life becomes better with the rhythm control. And these are the clinical considerations which should be taken into account whenever we consider. But I think most of the patient, whenever the trial should be given for the rhythm control. And I will be just skipping through this because we are. And when we all know this, that for the rate control also, there are certain medications, preferably beta blockers, calcium channel blockers, and digoxin can be used. But in decompensated patient, amiodarone can also be used for the rate control acutely. And in heart failure patients, that CCB should not be used for the rate control. And this one more important aspect, whenever the patient is going for the surgery, there is some patients are at the high risk of post-op AF. In these patients, short-term use of beta blockers or amiodarone can be used. And a patient who is going for the bypass surgery or valve replacement, posterior left pericardiotomy should also be done to minimize the risk of atrial fibrillation occurrence. And this is the anticoagulation protocol in the pregnant patients. So this is the most important slide, which summarizes the modalities of treatment in AF management: stroke risk prevention, optimize all modifiable risk factors, and symptom management, and then addressing the other comorbid condition to minimize the risk for the atrial fibrillation. Thank you.
Thank you very much, Sandeep. You have been quite comprehensive in a short period of time. And we have rather now luxury of time, as one of the speakers could not able to come and do it because his father is acutely sick. So we shall like to take up some of the questions, I mean some of the doubts which are there with the AF.
One thing which I skipped, I couldn't incorporate, maybe I skipped the most common, like atrial fibrillation with PCI subset, which I couldn't corroborate in my slides. So nowadays, with the AF with PCI also, there are multiple trials and meta-analysis, like Pioneer AF PCI, Augustus and Entrust. And as per them, whenever a patient is there for AF and PCI, then aspirin use should be minimized. Minimal should be 1 week. If there is more risk factor for the thromboembolism high risk, then it should be up to 4 weeks. And other than that, beyond 1 month, aspirin use is not recommended. Beyond 1 month, P2Y2 inhibitor plus DOAC should be the preferred agent for the maintenance of anticoagulation and platelet use. Clopidogrel is the more commonly used, but some patients are on ticagrelor also, so that can be also considered.
So I agree, it's very comprehensive and a very common topic, atrial fibrillation in internal medicine or cardiology practice. And there are certain things about atrial fibrillation which of course you have already shared, but I will like to highlight few points. These days they often talk about AF more because of device, you interrogate the device, or people are putting on now the Apple Watch, and Apple Watch records the episodes every 5 minutes, so you pick up atrial fibrillation. And Apple Watch is said to be quite dependable scientifically, and if the tracing is satisfactory, you can make a sense out of it. And so what is your take on this device detected atrial fibrillation? How do you deal with it? Because conventionally when the atrial fibrillation comes in mind, automatically we think of Chad West and the anticoagulation. So how do you feel about it?
So first and foremost thing, because many times we come across the Holter reports also, like few months back I got a call from my colleague that his father is admitted in Delhi and they have done Holter, and now they are saying that we have to start anticoagulation because Holter is reporting as atrial fibrillation. So whenever there is a device detected atrial fibrillation episode, first and foremost thing is that should be visually confirmed by the clinician whether it is an actual atrial fibrillation or it's some artifacts or something which has been reported. So clinical confirmation visually is the most important thing, and once you confirm that it's a clinical atrial fibrillation visually, that's diagnosis is there. Like in Holter, you can view the Holter records, and for the devices we can go for the intramyocardials visually to analyze the intramyocardial recordings to see whether it's atrial fibrillation. And then we have to see the duration.
I think we should continue with the next session because we'll be running behind time.
Our time is till 5:30? No? One more lecture. Our time is still this thing. Timing is still what time? 5:30. Oh, 17 minutes. Yes, yes. One more talk is there. So fine. So device related, the duration then decides.
Yeah. So duration I talked, it should be less than 5 minutes is not considered atrial fibrillation generally. If it is more than 5 minutes and more than 24 hours, then there is data for the anticoagulation.
Okay. So Now I think we should go to the next talk, and that is Dr. Naim Asafada, who talks about the recent update on the diabetes and CVD. Few of the updates he will highlight.
So that incidentally, where is Dr. Cherian? Okay, fine. All right, thank you.
Next. Good evening. Thank you, Dr. Mithun, for giving me this opportunity. And thank you to the panelists also. I'm going to be speaking about the 2023 ESC guidelines regarding diabetes with cardiovascular disease. And why do we talk about these diabetes? I think a lot of people think that this is done and over with, but the prevalence of diabetes is increased among patients with cardiovascular disease, with 23 to 37% of the patients with ACS and up to nearly half of the patients with heart failure are actually having diabetes. To summarize what the guidelines say now, any person who is already having atherosclerotic cardiovascular disease or a severe target organ damage is automatically classified as high risk, and the remaining people also should not be let go, and they should be classified using a scoring system, that is a score 2 diabetes. Less than 5% is classified as low risk, then 5 to 10% is moderate, and 10 to 20% is classified as high risk. More than 20% is classified as very high risk. All patients need to be classified. That's what they're trying to say. What is severe target organ damage? It is basically anyone having an eGFR less than 45. So basically it means that eGFR needs to be calculated for all diabetic patients, or the urine albumin creatinine ratio is also very important. Anything 30 to 300 milligram per gram is now class A2, stage A2 target organ damage. A3 is more than 300 milligram per gram. Or the presence of microvascular disease in 3 sites, basically say microalbuminuria plus retinopathy and neuropathy. So all these are classified as severe target organ damage. However, interestingly, in the data, they are mentioned clearly that there is not enough robust evidence to suggest the assessment of coronary artery calcium scoring or the intima media thickness for helping to reclassify cardiovascular risk, which is also very important because this has become a new fad somehow in diabetic patients. What to do and what not to do. Screening for diabetes is recommended for all individuals using fasting glucose, and it is recommended that it should be screened using fasting glucose or HbA1c. It is recommended to assess for cardiovascular risk in all diabetic patients, and all cardiovascular patients in the reverse direction should also be screened for diabetes. And whenever you have diabetes without symptomatic atherosclerotic cardiovascular disease, recommended to estimate the 10-year cardiovascular disease risk using a scoring system. Another thing they want to focus on is comprehensive lifestyle modifications, most prominent being weight reduction in patients with diabetes. Recommended that all patients with overweight or obesity status to reduce the weight and increase physical exercise to improve the overall cardiovascular risk profile. Another thing is nutrition. It is recommended now as per the European guidelines that to adopt a Mediterranean or a plant-based diet with high unsaturated fat content to lower the cardiovascular risk. As part of their comprehensive lifestyle modification, they mentioned that physical activity needs to be improved in each and every diabetic patients, even with or without cardiovascular disease. They recommended a weekly activity of 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise. In the 4th line, they also mentioned to perform resistance exercise in addition to endurance exercise at least twice a week. Smoking, obviously, we know, but it is important to reinforce this concept again and again. To stop smoking is class 1A indication always for all patients. And recommendations for glycemic targets is to apply tight glycemic control less than 7 HbA1c to reduce microvascular complications. But in line 3, it is clearly mentioned now to individualize the HbA1c target according to the comorbidities, diabetes duration, and the life expectancy also. So things need to be individualized for each and every person. Why we are discussing all these things? Because it has been shown in some very interesting trials like Look Ahead, where lifestyle intervention by nutrition, counseling, meal replacement, and exercise induced an average of 8.6% weight loss, which was associated with significant reduction in HbA1c and the blood pressure of the people. Addition analysis 16.7 years after in this long trial revealed that the participant who lost more than 10% of weight at 1 year of intervention had a 21% reduced risk of mortality, which is a very significant number equivalent to medical therapy. The Mediterranean style of eating pattern improves the glycemic control, lipids, and blood pressure. It's been shown in the Predimed study, and the risk of ASCVD was reduced by 28 to 31% in this diet. And if this diet is especially supplemented with some amount of olive oil or nuts, and the data from the study, now this is again interesting. Again, a new fad is being ruled out. Data from the studies on supplementation with omega-3 fatty acids do not support recommending a N3 fatty acid supplements for additional prevention of cardiovascular disease in type 2 diabetes. People with cardiovascular disease are encouraged to reduce their sodium intake because this reduces their systolic BP on an average by 5.8 mmHg in all hypertensive patients. Reducing the salt intake by less than by 2.5 grams per day results in a 20% relative risk reduction of ASCVD events. And intervention programs reduce HbA1c by 0.6% in patients with type 2 diabetes, which is equivalent to addition of one more drug, with the combination of endurance and resistance exercises having the most beneficial effects. Smoking cessation is a very important lifestyle modification because there is evidence to suggest that nearly 36% reduction in mortality is achieved. And if advice, encouragement, motivation is not helpful, then early starting of nicotine replacement therapy, followed by use of some medicines like bupropion or varenicline, along with telephone therapy, all increase the success rate, which is not being adopted at a common level. Electronic cigarettes have also been addressed, but it has been said that a consensus regarding the efficacy and safety of this approach has yet to be reached. So electronic cigarettes do not hold a high level of recommendation for smoking cessation. To summarize, they want the patient to be treated as a whole, not just a patient of diabetes with numbers and HbA1c. Obesity needs to be tackled, nutrition needs to be tackled, inactivity needs to be tackled, and smoking needs to be tackled. And 5 major complications, including HFpEF, HFrEF, atrial fibrillation, coronary artery disease, and peripheral artery disease, need to be addressed in all patients of diabetes. We have to hunt for these complications whenever we find diabetes. Now, a lot of things have been repeated, so I'm just going to briefly run through these slides. Recommended to use proven agents with proven cardiovascular benefits in diabetic patients rather than those older style drugs which may not have proven cardiovascular safety. SGLT2 inhibitors and glucagon-1 receptor agonists now have the class 1A indication, so they are to be prioritized for the treatment of diabetes. In the graphical form, GLP-1 and SGLT2 inhibitors now to be prioritized independent of HbA1c. If additional glucose control is required, then metformin and pioglitazone may be added, but again, pioglitazone only to class 2B because it is not to be used in heart failure. The agents are named clearly in the European guidelines. The DPP-4 inhibitors, 3 of them have been proven now at present to be cardiovascular safe. Sitagliptin, alogliptin, linagliptin, the others do not have that data. Artegliflozin is cardiovascular safe. Sulfonylureas, older, the latest one, glimepiride and gliclazide are the older ones. Insulin glargine and digludid are proven for safety, not the regular insulin. And other GLP-1 analogs, lixisenatide, exenatide, and even oral semaglutide have safety, but not to be proven to be cardiovascular benefit as of now. So only the injectable GLP-1 analog has the benefit proven. And finally, without safety evaluation, the short-acting insulin and older sulfonylureas still do not have any proven cardiovascular safety. These are the various trials has been discussed by my colleagues earlier, EMPA-REG, Outcome Canvas, Credence, and these are the SGLT2 inhibitors clearly have shown to be beneficial. And the other trials for GLP-1 analogs, basically Leader, Sustain, Rewind, Pioneer, a lot of them showing clear benefits and a hazard ratio in the range of 0.85, that is 15% relative risk reduction for patients with diabetes. So it is now again in the graphical form. If there is a very high risk after classification, then directly go for the GLP-1 analog and SGLT2 inhibitor. In moderate risk also, SGLT2 inhibitor remain as a important starting drug. Only in the low risk and moderate risk, metformin may be considered as a class 2A indication. Shorter life expectancy is a very important topic that has been touched. Here it can clearly shown that HbA1c less than 8.5% is now the recommended. So we have to be flexible as per the patient, not to always stick to less than 7%, which is for a normal person and a longer life expectancy. Lowers the hypoglycemia risk. Blood pressure should be found. Regular blood pressure measurements are recommended in all diabetics and should be treated. And the goal targets are essentially less than 130 for everyone, and less than 130. But if not tolerated, less than 130 if tolerated, but not less than 120. Especially in older people, it is recommended to target SBP of 130 to 139. Again, the emphasis being to be flexible as per the patient's condition. along with lifestyle change, physical activity, weight restriction, alcohol restriction, sodium restriction. All these are class 1 indications. Showing the flexibility and how to continue to hunt for blood pressure. Hypertension, clinically, they are diagnosing, Europeans consider as more than 140/90. But if there is some doubt, always go for ambulatory blood pressure monitoring. And similarly, if there is a high normal BP also, we should always consider for ambulatory blood pressure monitoring to hunt and diagnose this hypertension, which may remain hidden and which is not amenable to detection by any blood test or any scan. Lipids, we have to classify the patients and target different levels for LDL-C mainly. At a moderate risk for all diabetic patients, LDL-C target is less than 100. But for those at high risk, LDL target is actually less than 70. And those already at a very high risk with established cardiovascular disease, then the target is actually less than 55. So the targets have become more aggressive for lipid control. The same thing is repeated. These are all class 1A and class 1B indication for these targets. Statins are recommended as the first choice drug for LDL-C control. But if statin target is, with the statin target not reached, ezetimibe may be added. And if statin is not tolerated or still target not reached, then PCSK9 inhibitor should be considered, despite it being expensive, but should be considered always. Everyone should be given a chance. And two differences, antiplatelet therapy has been discussed. For ACS patients, 12 months of dual antiplatelet therapy recommended. But for CCS, chronic coronary patients after stenting in diabetes, 6 months of therapy is considered to be good enough. Atrial fibrillation has been discussed by my colleague, but there is a recommendation for gastric protection when antithrombotic drugs are used in combination, 2 or more antiplatelets. Then proton pump inhibitors are now a class 1 indication. But when clopidogrel is used, omeprazole or esomeprazole not to be considered. Revascularization has been considered. If heart failure is suspected, then to measure BNP always. And SGLT2 inhibitors, equilateral ARNI, beta blocker, MRA are now the class 1 indicators, the 4-pronged therapy. HFrEF, MREF is also now a class 1 indication for empagliflozin, dapagliflozin. And pioglitazone and DPP4 inhibitor, saxagliptin are not to be considered because they are class 3 indication. For CKD prevention, again, SGLT2 inhibitor, finerenone, as has been pointed out, and this is the comprehensive outline. For all patients with diabetes and cardiovascular disease, we have to hunt whether they have other comorbidities and try to solve this problem using the latest class of medicines. I will end this with new classes of SGLT2 inhibitors and GLP-1 analogs have been discovered, proven to have beneficial cardiovascular outcomes. The exact mechanism of these are not known. They have no inotropic chronotropic effects, but have been shown to improve cardiac diastolic function and possibly energy metabolism, which is a new direction. As of 2024, FDA has granted approval for subcutaneous semaglutide in non-diabetic adults with established cardiovascular safety and obesity or overweight status. So this is the latest one based on SELECT trial, and other directs are in the pipeline after latest trial results. The hidden part, done. Hidden part, mechanism of cardiovascular benefits in this guideline, it is clearly mentioned with proven efficacy remain incompletely understood. And this is what I would end it. Novo Nordisk is now the Europe's most valuable company, even though we don't understand how it works. Thank you so much. Thank you.
Yeah, thank you, doctor. Yeah, yeah, it is online. So just thank you for the exhaustive guideline.
Yes, it was a little bit long.
So briefly, what are the drugs you would recommend for a patient with DM and CVD, which we should keep in mind when we are writing a prescription? Which are the new drugs which you feel should be a part of the...
The commonly used are basically empagliflozin and dapagliflozin have very good data supporting them. So they are to be considered for all diabetic patients as a starting agent. That is what the guidelines need to are trying to summarize, especially for those who are already having cardiovascular disease or those who are at least at a moderate to high risk. So everyone needs to be considered. And for cardiovascular disease and obesity, again, the hit drug is Ozempic and Wegovy, and they are coming up in a big way. Cost reduction is required so that more and more people can get a benefit out of these drugs. Thank you.
So thank you very much for the update session. That's been very interesting. And these updates, you know, are how important it is. They protect you in the court of law also when you follow the guidelines, and that's known as the standard of care guideline directed medical therapy. So that's what we all follow. The trials may come to a different conclusion, but guidelines stays at least for 4 to 5 years till they are modified. All the speakers did an excellent job. I think we must give a clap to them. And thank you very much. With this, we end the session in time.
Thank you so much, Dr. Gupta, and for conducting this session. And thank you, Murli, Dr. Rupesh, Dr. Praful. So I might request you, Dr. Praful, and all, you can still continue. We have the last session. You can be on the panel. There's no problem. You can be on the panel. Come on. So last are 2 keynote lectures. You can all join, actually. It's all very small group now. So last session, Dr. Praful, you can also be on the dial. Okay. Yeah, sure. So this is the very last session. The most important one, not the most important one, one of the very important ones, of course. And we have 2 prolific speakers from USA. Dr. Fayaz Shaul, he is a very, very well-known cardiologist. When I was a kid in cardiology, even that time, he was well-established and well-known. So Dr. Fayaz Shaul is already online. Can you hear us, Dr. Fayaz?
Yes, I can hear you. Thanks very much,
Great.
Dr. Mittal.
Great. So we are in the last session of the meeting, and we are eagerly awaiting to hear from you, as always. And thank you so much once again for accepting my personal request to be part. And next year, I'm sure you will be joining us in person, hopefully. So with me, I do not have Dr. Lochan here. For some reason, he had to leave, and Dr. Atul Mathur could not travel. Maybe he will appear online. So now I also have my other colleagues on the dais, Dr. Rupesh and Dr. Rajiv Gupta, and we request you and welcome you, and we are starting your lecture now. Any words from you before you start the lecture, before we play the lecture?
No, please go ahead. Thanks, Dr. Mittal, for your kind invitation.
Thank you.
Good morning, Dr. Mittal, for your kind invitation. I'll be speaking on high-risk PCI in acute coronary syndrome. I have nothing to disclose. When do we use mechanical circulatory support, or when do we use hemodynamic support in acute coronary syndrome? Well, as we know, most PCI by far does not require hemodynamic support. Now, which patient are we talking about who may need a mechanical circulatory support, what I call MCS? Well, we're talking about patients with complex coronary disease, multivessel coronary disease, left-main coronary disease, patients with hemodynamic compromise, a depressed ejection fraction of 35% or lower, particularly if they are in heart failure, particularly if their right heart hemodynamics reveal high filling pressure, as well as comorbidities like acute coronary syndrome, acute myocardial infarction with shock, cardiac arrest, LV and RV failure, complex lesions, associated valvular disease, diabetes, peripheral disease, advanced age, and prior bypass graft surgery. And when we use hemodynamic support or MCS, we call this protected PCI. What are we trying to accomplish when we use a mechanical circulatory support in these high-risk patients? First and foremost, we want to maintain hemodynamics. Number 2, facilitate safe and complete and optimize revascularization. And finally, maintain case safety, provide adequate support so that complications can be managed prior to clinical decline. Now, what kind of mechanical circulatory support we have available for high-risk PCI? One is the most common, almost every cath lab has it, an intra-aortic balloon pump, or axial flow like Impella CP, or centrifugal flow, tandem heart, or VA ECMO. Now, intra-aortic balloon pump has pros and cons. First important thing is a well-known technology is, as I said, is available in most cath labs. It does increase the coronary perfusion, but only mild increase in cardiac output. Very easy to use, much lower cost than the other devices. Con, it does require a minimum of some cardiac function. It requires a stable rhythm and modest unloading, and it requires native LV pulsation. Now, what we have data on internal balloon pump in high-risk PCI. This is BASIS-1 trial showing outcome between elective balloon pump or no balloon pump. And there was no major differences between the two in terms of in-hospital MACE, but there were lower procedure complications like prolonged hypotension, VT/VF arrest, CPR required ventilation, lower in balloon-supported patients versus no balloon-supported patients, and 12% of the control had to use as a bailout intra-aortic balloon pump. Although there was not much difference in the initial period, but if you look at this curve, at 5 years, all-cause mortality was much lower in the balloon pump supported PCI versus no balloon pump supported PCI. Now, how about other devices like Impella, which can increase the cardiac output from 2.5 to 5 liters, depending what size Impella you're going to use. It does increase coronary perfusion pressure, LV unloading, reduction in myocardial oxygen demand, and increases the organ perfusion. And Impella RP can be used in RV failure up to 14 days. Now, this is a PROTECT 2 randomized trial, prophylactic hemodynamic support using Impella 2.5 in non-emergent high-risk PCI, undergoing PCI to unprotected left main or last remaining conduit and an EF of 35% lower, or three-vessel disease and an EF of 30% or lower. It was one-to-one randomization between balloon pump and Impella-supported PCI. There was no difference in hospital MACE, but the MACE was lower both at post-discharge as well as at 90 days. But it was also interesting that Impella reduces MACE with more complete revascularization. I think patients who underwent 2 to 3 vessel PCI on Impella had lower MACE than patients who were supported by balloon pump alone. In addition, in the PROTECT 3 trial, which was a sub-study, showed acute kidney injury much lower with Impella-supported patients than with control. But what are the considerations one should keep in mind when you try to select the right device? It all depends whether you need a univentricular or a biventricular support. If you need a biventricular support, you may need an ECMO. But it also depends on your vascular access, which is very important. How is the iliofemoral anatomy and patient substrate? Also, you have to make sure you have critical care resources and training after post-procedural events. Also, you need to know cath lab and nursing staff ability to support device use. And finally, the cost. I think cost may be also very important between Impala and a balloon pump. Now, if you look the matrix for comparing different types of MCS, balloon pump giving you support up to cardiac flow up to half a liter, Impala up to 4 liters, tandem heart up to 6 liters, VA ECMO up to 7 liters, but it does come with some problem of hematomas, because there are large bore catheters, problem of transfusion and reintervention because of vascular complication. And we have also noted that people who have bleeding complications, they have high in-hospital mortality, and also the length of stay is longer. Now, it's important when you have a patient undergoing complex PCI, when to use hemodynamic support and when not to use. You have to ask yourself a few questions. First question is the patient hemodynamically deranged despite medical optimization? They are still hypotensive, they are in heart failure despite medical management, then you need support. Second question is, does the patient have the reserve to sustain a brief ischemic insult? In other words, is the patient has low EF, has the patient reserve to sustain a brief ischemic insult during intervention? If no, you need a support. If yes, then take another question. Question 3 will be then, is the patient at risk for a complete interruption of a blood supply that will lead to hemodynamic collapse? Yes, then you need a support. No, and go to the next question. The last question is, does the patient have limited reserve? And is the patient at risk for prolonged ischemic insult, limiting one's ability for completely revascularize the patient or subject the patient's ventricle to stunning? For example, I'll show you a case with severe LV dysfunction who will need extensive rotoablation in a low EF. There you want to use some kind of support. Now, if you have answered these questions, then you think you may not need a support, but patient is high risk, you should definitely do a right heart catheterization to check their hemodynamics. And also always keep in mind to keep a second access. In other words, have a bilateral access should there's a problem, you want to go to hemodynamic support. However, in the PROTECT 3 trial, we found that if you use prophylactic support, the hospital mortality was 4.3%, versus if you have a complication crash, you put a hemodynamic support, the mortality was 49%. That you have to keep in mind, although this was not a randomized trial. Let me share with you 2 case examples of acute coronary syndrome who has high-risk features. First patient is a 79-year-old diabetic patient with a non-STEMI, troponin over 4,500, and in heart failure. And this is the electrocardiogram showing extensive anterolateral, this Wellens kind of syndrome, T-wave inversion. And this is his ventricle, very poor LV function. Ejection fraction was estimated at 20 to 25% with severe wall motion abnormalities. In addition to that, the patient had mild to moderate mitral regurgitation, and the coronary angiogram shows heavily calcific left main, proximal LAD, mid LAD, as well as proximal right, which gives collaterals to the left side. Now, because of his low ejection fraction, complex coronary anatomy in the setting of non-STEMI and heart failure, the operator placed a balloon pump after the catheterization and was referred for coronary artery bypass graft surgery. But prior to scheduled bypass graft surgery, while on intra-aortic balloon pump, patient had chest pain, heart failure, and new EKG changes during chest pain. As you see here, previously had extensive anterolateral T-wave inversion. Now from V1 to V4, he has upright T-waves, like pseudo-normalization equivalent to transmural current of injury. Now 79, previously disease, low EF, hemodynamically not stable on balloon pump. Patient was turned down for surgery. We know patients who have been turned down for surgery have a worse outcome than patients who are high risk for surgery. So you want to do best in this patient. So in a balloon pump, what we did is, since he had already issues on balloon pump, we placed an Impella on this patient. And you can see here on Impella, the repeat angiogram continues to show very critical calcific left main and long LAD lesion with an LVDP was 22 on balloon pump, by the way. And he had an extensive rotoablation of the left main, proximal LAD, mid LAD. Was a very complex case, required guide liner and other things to place the stent, was done at IVUS guidance. The left main area was finally 12.5 millimeters square with excellent angiographic results. And after that, we did the right coronary artery before and after the intervention, and with no further collaterals to the LAD. And he was subsequently weaned off Impella in the cath lab and was discharged on day 5th on guideline-directed medical therapy for his low EF, as well as was discharged on a life vest. But look at here, dramatic improvement on his LV function after 1 month by echo. You can see no further mitral regurgitation at 1 month echo with normal LV. And just for comparison, there's a baseline echo showing severe LV dysfunction, wall motion abnormalities, and post left main LAD and RCA intervention on Impella, a normal LV function at 1 month, indicating that he had a very bad stunned myocardium. Next example of a patient with high-risk features, 87-year-old woman with heart failure, with non-STEMI, BNP over 6,000, and echo shows EF of 40% with moderate MI, wall motion abnormalities, and a echo showing P gradient of 72 with a mean of 38. So you have critical AS and very serious critical left main, ostial LAD, ostial circumflex, very complex intervention if required. And this is another view showing very nodular calcification of the distal left main involving bifurcation. So when at a hard team approach, it was felt that this patient is very high risk for surgery, and AVR was referred for high risk PCI and BAV. And here we are. She had LVDP pre 22, gradient 70, the mean of 38. And what we did first is the balloon aortic valvoplasty as a bridge to the tower on Impella. Following BAV, you can see repeat angiogram of the coronary shows still very calcific lesion. Had a very good rota bladder had to use a small bird to start with. This is pre and post results of Rhoda stent of the bifurcation on Impala. Another view showing very good results post Impala, roto stent, and this is the left main IVUS final 11.9 millimeter square of the left main, and patient was taken off the Impala in the cath lab, was transferred to transcare unit, and was discharged next day with the return to Tower. Had Tower 6 weeks later, 23 millimeter Sapien 3 with follow echo showing no PVL, normal LV function, and no wall motion abnormalities. So I like to conclude that MCS can help accomplish high-risk PCI and acute coronary syndrome, potentially minimizing the risk of severe complications and allowing a more controlled procedure in selected patients. MCS selection requires thoughtful consideration of indications and clinical purpose, and hemodynamics are very important, very essential for MCS need and device selection. Finally, patients with stable hemodynamics will likely receive complete revascularization and thus better long-term outcome. Ongoing randomized PROTECT IV trial is currently underway, which will be more specific when to use a hemodynamic support. So this is the PROTECT IV trial going on, almost 2,500 patients between Impala CP or Impala without Impala as control, although one can use a balloon pump in the control arm. Thank you for your kind attention. I'll be happy to entertain any questions.
Thank you very much. Now we will have some discussion. Dr. Rajiv Gupta is with me, so he will start, please.
Thank you, Professor Faisal. Your talks are always very interesting and very challenging. And I agree in patient with the high risk, these CHIP cases with the acute coronary syndrome, when you are obliged to do the thing procedure in the cath lab and they denies the cardiac surgery or the surgeons denies they're taking up the patient, these MCS are the need of the hour. And we will not fear to use MCS because MCS gives you extra protection. It makes you operator more comfortable, confident. You can study the anatomy. You can use the imaging devices more comfortably, including OCT, to plan your procedures, and you can do the procedure more intelligently and in a more confident way. It may take a little more time. It may be a little expensive, of course, because the issue is sensitive. But MCS have a definite role to play here also. And I agree, rightfully, there is a design trial which has been beautifully done, and maybe trial is underway, and soon, maybe in a year's time or so, you get the results. Then it becomes a standard practice, comes in the guideline.
Thank you very much.
Yeah. So
I may want to.
Yeah.
I may want to just add. There was a paper just published in New England Journal of Medicine 2 weeks ago. Danger shock trial. This is the first trial ever shown that the Impala CP had the lowest mortality, which was just published. So that was in cardiac shock patients. So it took 10 years for them to complete the trial, but the PROTECT IV trial is going on. So I think we're going to know more whether it is beneficial and which patients are the best for hemodynamic support, particularly Impala.
Yeah. Dr. Rupesh.
Both cases are excellent. And second case, just wanted to know that Impala crossed before doing ballooning of the aortic valve, or because I am seeing the images, it is showing the Impala is already there before crossing the, like before doing the balloon valvoplasty. So how it was crossed like that? Just wanted to know.
Okay, now since this patient had a very severe aortic stenosis, hypotensive, heart failure and critical left main. So what I do is I put the Impala first. You put two pigtails in the LV, exchange first pigtail with the Impala, and then put a BAV by the side of Impala, but not use more than 15 or 18 millimeter balloon. I have done about half a dozen cases. It's also published. You can do it while the Impala is across the aortic valve.
Okay, thanks for clarification. But this is coming in my mind how it was done. Thank you.
And that's always a challenge, when you have critical AS and bad coronaries, and patient has been turned down. She's 87. The mortality is very high with critical AS and heart failure and with concomitant left main disease, and it's the only way to do that in a safe manner.
Second case was great saving because he was so old and declined by surgery, having the severe AS, left main so heavily calcified distal left main. So it's a great saving. Congratulations.
Yeah, that was an excellent, those both cases were excellent and very insightful that lives can be saved with the proper technology and technique and a good support system.
But there's one thing, very careful that these are large catheters, 14 French. So one has to be very careful because they are, in centers who are not used to large bore catheters have a higher vascular complication. In fact, the trial just published 2 weeks ago, a danger shock trial showed lower mortality, first time ever shown with Impala, but there was a higher vascular complications. I have also learned that people who do TAVRs and are used to large bore catheters have a lower complication vascular as compared to one who used it occasionally. So that is very important to keep in mind, and that there are more vascular complications.
Yes, Professor Faisal, I have a question. What I think, if the patient has aortic regurgitation also, which is significant, then what about this your Impala and other things, how far they are going to help you and how far you are comfortable to use them?
I think that is one issue. You can't use a balloon pump with AI, but people have used an Impala. I have not used an Impala with AI, but I think if somebody is really going down the drain, I think ECMO is far more superior in that setting than the Impala, if you see with AI.
Right. Thank you for clarification.
Thank you, Dr. Faisal. If any other question for discussion from Dr. Shawl? Else we move forward. Dr. Shawl, many thanks once again for illustrious cases.
My pleasure.
And
my pleasure.
By all means, we should be seeing you in person next year. We are missing you.
I hope so.
Yeah, we do hope so. Yeah, thank you so much.
Yeah, I have been listening to a meeting, great meeting, and so much to learn.
Thank you so much for your encouraging words. And if you wish, if you would like to stay on, we have the last.
Oh yes, I will stay on, of course.
Yes. So we have the last lecture, which is from Dr. Robert Giuliano. Previous year also, he had given a wonderful journey from through the TIMI trials, and we are fortunate again, Dr. Faisal, you and Dr. Robert Giuliano to have once again with us. And Dr. Robert, are you able to hear me?
Yes, I am. Can you hear me okay?
Good morning for USA and good evening from here.
Yes, good evening to you all, and thank you very much, Dr. Mittal, for again inviting me to participate.
Thank you.
I'm looking forward to attending next year's meeting. Sorry I could not make it this time.
Probably, or maybe certainly, we should plan in such a way well before that you both can come and attend in person.
Yes, I'd love that.
Yes. I would like to introduce to the audience, Professor Robert Giuliano is the Senior Investigator of TIMI Study Group, a staff physician, Cardiovascular Division, Brigham and Women's Hospital in Boston, and he is very well known in our field. So please, Dr. Robert, we'll start your lecture, pre-recorded lecture, followed by the discussion. Thank you.
Hello, this is Dr. Robert Giuliano. I'm pleased to be participating remotely in this year's SHAKEHEART 2024 annual conference. Thanks to Dr. Brajesh Mittal for inviting me to present on a journey through 40 years of TIMI trials. And in the next 20 minutes or so, I'd like to share with you some of the important findings from our research group. Here are my relevant disclosures. These relate to research grant support for performing clinical trials and various relationships I have with companies in the lipid and anti-thrombotic space, CME programs, lectures, and consulting. I have 4 objectives for today's talk. I hope by the end you understand where clinical trials fit in the cycle of clinical therapeutics. I'll be describing the cardiovascular guidelines that are related to TIMI trial findings so you can see how clinical trial results translate into changes in guidelines and practice. And then I want to focus on some major findings from the most recent trials of interest and briefly touch on future avenues for clinical research. This slide depicts the cycle of clinical therapeutics that Rob Califf initially described over 20 years ago, where somebody has a concept for a new treatment or intervention. It's studied in clinical trials. If it's effective, can make its way into guidelines and serve as performance indicators. And then as outcomes are assessed, sometimes others or folks can come up with an even better idea to be tested again in clinical trials, and we go through the cycle again. Our group has been involved in clinical studies since its foundation in 1984 by Dr. Braunwald, and since 2011 chaired by Dr. Sabatine. The TIMI study group is the oldest cardiovascular clinical trial group, academic research organization in North America. Currently, we have 13 cardiologists, 10 statisticians, and over 70 operational staff to help us lead these often large multinational randomized trials. Some are as large as 30,000 plus, although we have done some smaller studies, including some phase 1 studies with just several dozens of patients. Here is shown are the breadth of trials that we have performed over these 40 years. 89 in total, 76 are completed. In the center are those in acute coronary syndrome, which is where TIMI started, in ST elevation MI, then branching out into non-ST elevation ACS, in percutaneous coronary intervention trials, and then more broadly into primary and secondary prevention, cardiometabolic, atrial fibrillation, et cetera. The very first trial was published in April of 1985, and this is the initial TIMI trial comparing TPA with streptokinase. You notice that there's no number here because it was the first TIMI trial report, and the first patient enrolled was almost 40 years ago on August 20th, 1984. The primary findings of the initial TIMI trial was that TPA was superior to streptokinase in opening up occluded coronary arteries in acute ST elevation MI. You see this patency rates of 70% compared to 43% TPA versus streptokinase. Now that led to a decade or more of studies focused on ACS patients, where we established a better flow, lowered mortality, developed various scores and then scales to assess bleeding, reperfusion, including frame count and myocardial perfusion grade, more effective anti-thrombotics, as well as fibrinolytic agents, and various risk scores and strategies to improve care, moving quickly and early in highest risk patients. The second decade of trials, I want to call out 5 studies, or 5 areas of research. As adjuncts to fibrinolytic therapy, we learned that clopidogrel and enoxaparin improve cardiovascular outcomes in the Clarity TIMI-28 and Extract TIMI-25 studies. In Prove-It TIMI-22, intensive statin fared better than moderate intensity statin in patients with recent ACS. That was atorvastatin 80 milligrams. We studied and showed for the first time that a more potent P2Y12 inhibitor here was prasugrel, studied in TRITON-TIMI-38, was more effective than clopidogrel in preventing cardiovascular events in ACS patients treated with PCI. And in the early ACS trial, a study I was involved in, I learned that early routine use of the glycoprotein inhibitor eptifibatide, an intravenous agent, early use routinely led to more bleeding and not necessarily better outcomes. And so late provisional use in the catheterization lab then thereafter became the standard. And then ranolazine, a study with anti-anginal properties, a drug with anti-anginal properties, was studied in the Merlin-TIMI 36 trial. And in these patients with non-ST elevation ACS, ranolazine did not reduce a recurrent MI or cardiovascular death, but interestingly was very good for controlling angina and had favorable antiarrhythmic properties with less atrial fibrillation and fewer ventricular arrhythmias than placebo. You can see how many of these studies translated into the subsequent US guidelines here, both in STEMI at the top and non-ST elevation ACS with regards to lytic agents, anticoagulants, antiplatelets, and different strategies on how to treat patients, and of course, high-intensity statin. The next decade in the 2010s led to a more diverse series of studies in ACS, lipid-lowering diabetes, and other areas of cardiovascular medicine. I've selected just, I think, 5 studies to share with you. In the post-ACS setting, patients more than 1 year after myocardial infarction, we learned in the Pegasus-TIMI 54 trial that ticagrelor was more effective than placebo, and this is on a background of aspirin, to prevent future cardiovascular events, even though these patients are more than a year out from their MI. The lower dose ticagrelor, 60 milligrams, had less bleeding, and so was subsequently approved after this study for use in patients who had an MI more than 1 year ago. For those who are going to continue on dual antiplatelet therapy, here everybody was on a background of aspirin. In the IMPROVE IT trial, we studied ezetimibe on top of background statin therapy as compared to placebo. And this was a landmark trial because it was the first study to show that a non-statin lipid-lowering agent, when added to statin background therapy, would reduce cardiovascular events. You see a 2% absolute risk reduction in IMPROVE IT with ezetimibe, and that's despite rather modest effects on the LDL, about 17 milligrams per deciliter, and only 0.5 milligram per deciliter reduction in CRP. Of course, we continued studies in lipid lowering, and a much more potent class of agents are the PCSK9 inhibitors. In the FOYE trial, we evaluated evolocumab, a subcutaneous injection of monoclonal antibody to PCSK9, found that it dramatically lowered LDL by nearly 60% from a baseline of 2.4 millimoles to 0.8 or less than 30 milligrams per deciliter. This translated into a 15% reduction in the primary cardiovascular composite, or a 20% reduction in the key secondary endpoint of cardiovascular death, MI, or stroke. We did not see a floor to the efficacy with regard to achieved LDL. You see LDLs even below 0.5 millimole per liter were associated with better outcomes. In the field of diabetes, we studied initially dapagliflozin in a trial called DECLARE. This is a very large study in diabetics, over 17,000 patients, and learned that this SGLT2 inhibitor significantly reduced cardiovascular death and hospitalization for heart failure, and also tended to reduce major adverse cardiac events. Not only does it lower glucose, but prevented cardiovascular events. On the safety side, dapagliflozin, like other SGLT2 inhibitors, reduced the incidence of major hypoglycemia and prevented acute kidney injury, but also had side effects, a slight increase in diabetic ketoacidosis and an increase in genital infections. We also studied in patients with atrial fibrillation in the ENGAGE-AF TIMI 48, one of the novel or non-vitamin K oral anticoagulants, NOACs or DOACs, if you will. ENGAGE was the largest and longest study of a DOAC versus warfarin, and the agent studied here was edoxaban, as compared to warfarin, which was very well managed, a time in therapeutic range averaging 68.4%, we found that the higher dose edoxaban regimen, 60 milligrams, dose reduced to 30, which is now the standard regimen and the approved regimen for use, reduced stroke or systemic embolism by 21% compared to warfarin. The lower dose regimen, not approved for use, 30 milligrams reduced to 15, was rather similar to warfarin, a slightly higher rate of stroke or systemic embolism, but met non-inferiority. Both of these dosing regimens of edoxaban significantly reduced major bleeding compared to warfarin. And of course, the lower dose had even less major bleeding. And the other trial I wanted to mention from this era was the Pioneer Heart HF study with the sacubitril valsartan compared to enalapril. This was a smaller study in patients treated over the short term. What we were looking at was, as a primary endpoint, a reduction in BNP, and we saw that even starting at 1 week, sacubitril valsartan had a greater effect on BNP lowering than enalapril. We were somewhat surprised to see in this modest-sized trial, 881 patients, that the serious composite clinical endpoint of death, heart failure hospitalization, or need for advanced LV therapies was significantly reduced by over 40%, favoring sacubitril valsartan. Now, I want to spend a bit of time on 4 of the most important recent studies that we have completed and published. The Foyer trial with open-label Foyer-Ole study, an open-label extension study of evolocumab was recently published in Circulation by Michelle O'Donoghue. And just by way of reminder, patients in the Foyer trial could continue on at the end of that study, which lasted a little over 2 years on average, to an open label extension where all patients received evolocumab for a total of 5 years. What we learned from this open label extension is that patients who had been initially randomized to evolocumab and then continued on for another 5 years had a further 15% reduction in the primary cardiovascular composite, a 20% reduction in the key secondary endpoint. And perhaps the most important finding from the open label extension is we also saw a 23% significant reduction in cardiovascular death. Now, you may recall from the main Foyer trial, there was no difference in mortality outcomes. But it's because it was too short. If you continue evolocumab for another 5 years, you see these curves diverge, favoring long-term use of the PCSK9 inhibitor. Another study by Michelle O'Donoghue called Ocean-A Dose TIMI 67 investigated a lipoprotein A inhibitor, olpasiran. It's a small interfering RNA, and this is a dose-ranging study. You see at higher doses, greater than 80, even greater than 90% with the 2 highest doses, reduction in Lp(a). A phase 3 outcomes trial is now underway. COVID Pact, performed during the COVID pandemic, evaluated the VTE prophylactic dose anticoagulant versus full dose anticoagulation in a 2-by-2 randomization. There was also embedded a study of clopidogrel versus no clopidogrel, and this was performed among patients very sick with COVID in the ICU. The first part about the 2 levels of intensities of anticoagulation showed that standard dose anticoagulation was inferior to full dose anticoagulation for prevention of venous or arterial thrombosis. So you prevented more, significantly more, thrombotic events with full dose anticoagulation. That should now become routine in our COVID ICU patients who can tolerate full dose anticoagulant. On the other hand, there was no difference with clopidogrel versus no clopidogrel. It did not prevent venous arterial thrombosis. And then the last of these new studies that I want to share with you is a very interesting compound, a monoclonal antibody to factor 11. So a new class of anticoagulants that are being studied in patients with atrial fibrillation and other indications. In this study, Azalea TIMI 71, we compared abelacimab versus rivaroxaban in patients with atrial fibrillation. The primary endpoint, because it was a modest-sized trial, a little over 1,200 patients, was reduction in bleeding. And we saw that both doses of abelacimab significantly reduced bleeding. In particular, major GI bleeding was dramatically reduced. Ongoing studies currently are shown on these next two slides. We continue to evaluate PCSK9 inhibitors, inclisiran in the Orion-4 study, which is an RNA synthesis inhibitor administered intravenously twice annually. We are also continuing to study evolocumab now in even lower risk patients, those without a history of MI or stroke. We're studying dabigatran in acute heart failure to see if it can modify early heart failure events. Goldilocks TIMI-69 is looking in a different direction at a potent anti-inflammatory drug that blocks oxidized LDL at its receptor. And here we are studying serial coronary CT angios to look for changes in atherosclerosis over time. Several trials in the core family are ongoing. Some are wrapping up. This is an antisense oligonucleotide to ApoC3 called olezarsen. It's an injectable drug given subcutaneously every 2 weeks that lowers triglycerides through inhibiting ApoC3. Garden TIMI-74 is an interesting program study, a monoclonal antibody that targets GDF15 and looking at clinical outcomes in heart failure. I mentioned then the next phase 3 studies that we're doing with the lipoprotein a reducing agent olpasiran, which is a small interfering RNA inhibitor, in an outcome study to reduce Lp(a). I had also mentioned the monoclonal antibody to factor 11, abelacimab, in the LILAC TIMI-76 study is being compared to placebo in patients with AF who cannot take standard anticoagulants, unsuitable for anticoagulation. And lastly, an oral PCSK9 inhibitor is being studied in the Coral Reef Outcomes TIMI-77 trial, and that's a large outcome study. In the future, I think we'll be looking to harness genetics and systems biology to optimally identify targets and also use biochemical, genetic, and imaging data to better identify patients who may respond to the newer therapies. It appears that one size doesn't fit all when it comes to pharmacologic interventions. So we're often, and I think we will continue to study multiple doses and try to tailor it for a particular patient and use smarter trial designs, adaptive, simpler procedures, and leverage social media and modern technology. I hope now, after this rapid review through 40 years of TIMI trials, you can see where these trials fit in the cycle of clinical therapeutics. And for those who are interested to read more about the TIMI study group, Dr. Sabatini and Braunwald published this focus seminar in the Journal of the American College of Cardiology in 2021. Well, thank you very much for this opportunity and hope to see you next time in person. Thank you.
Thank you. Thank you so much for an elegant journey through the TIMI trials in the last 4 decades with the future insights and the ongoing trials. I have my co-chair, Dr. Rajiv Gupta and Dr. Rupesh. So please.
Thank you very much, Professor. Very interesting to listen to you. And you are the light for the cardiology world. What the work is doing is amazing. And this is the work which throws the light and guide us how to treat our patients. So basically, you are the leader to teach us and to tell us how to treat the patient and how to improve their outcomes in further way and with the newer molecules which are coming. They have changed the face of cardiology before our practice over the last 30 years, which I am witnessing. Amazing changes which we never thought 30 years or 40 years ago that the day will see like this. And so these are all results of the successful trials. And trials means inclusion in the guidelines, and guidelines means passing on to the bedside of the patients all over the world. So these guidelines not only guide the practice in the United States or in America or limited world, they guide the practice globally all over the world. So that's a very interesting point.
That's a great comment, Dr. Gupta. And we have seen our cardiology practices starting with the TIMI trials, and continuously these are evolving, coming newer and newer science and data. And we also have Dr. Fayaz Shaul online, and he's a contemporary actually. He has seen his entire life through TIMI trials. So Dr. Fayaz Shaul, do you have any comment, any thoughts from your side?
First, I want to congratulate Dr. Grano on a wonderful talk, and let me summarize it. We wouldn't practice clinical medicine what we are doing today without the TIMI trials. We were not being able to, really give good to our patients without the results from the TIMI trials. Again, thank you very much, Dr. Giuliano, for a wonderful presentation, and to give us the whole, right from the time Dr. Brownwald started it, almost 40,000 patients involved in these trials is phenomenal. And as has been said, we wouldn't practice without these results.
Thank you very much for your kind words. Thank you. I mean, for me personally, I was just so lucky to be able to join this group in 1996, and I've never had a second thought of, leaving or can't imagine a better position. We have a terrific group here, and Dr. Braunwald, he'll be age 95 this summer, and he's still active. And in fact, he called me late on Friday to say in one of the papers we're about to submit that we had made a minor grammatical error. So he's still correcting our papers at almost age 95. The other comment I wanted to make is one of my goals for the upcoming year is to be more involved in the Gulf countries. And I would like very much to bring the TIMI trials to the Gulf countries that are capable to perform, such studies, because I think we're overdue. We are overdue. Hearing this conference now for several years, it's clear the level of the medical practice and the science is equal to the other countries we're in, and better than in some other regions. So you'll be hearing more from our group, and I hope to be collaborating in the very near future.
Oh, that's great. Thank you so much. We'll have two more quick comments. One is from my colleague, Dr. Rupesh Singh, who is sitting here. He's an interventional cardiologist.
Yeah, thanks, sir, for your nice this revision whole. The TIMI trial is starting like almost 39 years, and we have gone through all these trials and changing practice guidelines, and we are looking forward for your two new trials, particularly the small RNA-induced lipoprotein inhibition as well as triglyceride reduction, because both are, you can say, still difficult to treat condition, and we are hoping in the future some more therapeutics are available after trials, and which comes in our guideline also.
Yeah, wonderful. We also have Dr. P.K. Gupta. He's an academician by nature, so it will be very, very good to hear from his side.
Yeah, I think it's a really exciting journey which you have shown to all of us, and we all know how we evolved ourselves as a clinician and cardiologist, and giving best to our patients on the background of TIMI trials, and ultimately coming to the guidelines. Because ultimately, whatever we do with an aim that we should improve the quality of care which we provide to our patient, we should be able to prolong their lives, and these trials are backbones for those data. So I'm really thankful for giving an excellent presentation describing the whole journey of the TIMI trials, and we are hoping for some of the good trial results in the future, and hope to see you next year physically in Dubai. Thanks for your again. Thank you.
Thank you, Dr. Gupta. Friends and colleagues, ladies and gentlemen, last 2 minutes are only for giving you everybody a word of appreciation from my side personally and my team. So now we have Dr. Fayaz Shal and Dr. Giuliano who are still online. So please accept my sincere gratitude for taking out time. And I know it is not easy to pre-record and then you are sent back the presentation, you have to re-record. So I'm so indebted to you for putting up your efforts into this. And please accept my personal gratitudes. This whole day has seen a number of lectures and truly our faculty, 40 people, they did a wonderful job in putting up their efforts and presenting a great data. Many of them chaired the sessions. Many of them are still online. Some of them are physically present here. We are very, very thankful to them. And people who have supported from the back are my team. We are truly thankful to you all, guys, audiovisual, event organizers, everybody who has supported and contributed. And last but not the least are the industry people. They have, without their financial support, such kinds of meetings cannot happen. They provided academic support unconditionally and without any interference in the academic program from their side at all. So thank you. A very good evening to everybody. See you next year. Thank you, everybody. Thank you.
Thank you very much.
Thank you. And this whole proceedings are recorded and will be available after a few days. If anybody has missed, can watch, can recap the missed lectures, or can go through whatever lectures they like to hear. We will share the link. Thank you so much. Thank you.
Thank you.
Thank you. Bye-bye.
Bye. Thanks. Bye.
Thank you, Brajesh, for organizing such an excellent meeting with a galaxy of experts from around the globe. That's very impressive.
Thank you.